Thank you to the chair, and thank you for giving me the opportunity to talk about this. Those are my disclosures. So we've had fantastic and excellent talks, and now we've actually decided what we're going to do. We're still dealing with how to fix these implants in place, and we've had these challenges where nearly half of them end up being malpositioned. I mean, they do well, but that malpositioning is a challenge, and then you end up finding that you end up having all those complications in terms of loosening, notching, and those impingements, particularly the external rotation. And what's come up since then is, during my fellowships, Kashif would know, we were doing blueprints, and we found that was fantastic. And then you go to the US, and then they gave you PSIs, and you put the pins in, and then you're still asking them, and John McFarland and all those guys would just wobble that wire and say, look, it is there. And then when you put the implant, and you see, okay, right, but the plastic has now changed to a definitive component, and it's not fixed where it is, and whether or not this is going to loosen up. I mean, these are questions that have remained unanswered. And then before we and obviously these modalities have been discussed with yourselves. We, previously get these CT scans, we get these 3D printed models, and we sit and decide, and we put wires in and do what we feel like. But just before I was heading out, I'm not sure if you guys are using the Exact Tech variety, and that is fantastic. That's brilliant. It is all live. You're just looking at it, and you can go on and say, wow, this is good. And what we're trying to achieve is, minimum margin of error, and you're looking at about 5 degrees in any plane, really. And inclination angles in myself, I'd be probably closer to the 18, 20 degrees conventionally, which has dropped way down to, less than 5%. And that confidence of getting that screw further in is much more with augmentation and navigation. And if you look at the data, so you're looking at the Scandinavians doing more than 3,500 of these with good 10-year stability. AAOS, well, they log it. I still don't understand the system, but they've got more than 56,000 of these procedures. And NJI data, I'll go, preview it through the slides. But if you look at it, it's the Aussies are leading as far as navigation is concerned, and I guess legislation and funding has got something to do with it, especially in the private sector in Australia. Kashif could allude to it, but you're looking at around 11,000 of these. A couple of years back, the reverse has got a fantastic, success rate and longevity around 97%, and we all know now that if you're doing more than 10 cases a year, the revision rates are lesser. I mean, I've just recently moved hospitals, but before that I was nearly touching that. And when you move to a different hospital, especially in a constrained economic environment here, it certainly dips. But that's where you start thinking now, if I'm going to go back to another shoulder, am I going to make those mistakes? And that's where we end up wanting to invest more. There's low compliance in terms of reporting it back. I guess these are old patients, and I think NJR would end up needing following them up telephonically if at all possible. So what we're looking for is a better alignment. We're looking to fix it better, hoping that there's a low complication rate, especially in a fully fledged private practice. I would rather invest a little bit more money into it and them not coming back with a complication. Yes, it increases OR time, and for our hospital it's about 407 rupees per minute, but again, I think in the long term, if a reverse or whatever implant fails here, you're looking at adding another 700 to 700,000 to 1.5 million of an implant here. But we do have limited long-term data. And this is, if you've not had it, go to a workshop and try this, and this is amazing. I think this is the way forward. You put these goggles on, most of you would have Meta anyway, and then what you're doing is, this is haptics versus reality. You're in there, you're using your hands, you're switching around, you're getting implants where you want them to be. And there's somebody sat on the computer, like you rightly said. You just line it up to the scapular plane, and then you get on and put in that dreaded wire of death. We don't have that here, but I respond by doing live fluoroscopy screening, and that, one, it's very difficult. I do beach chairs. It's very difficult to get a scapular view or an axillary view, but what we do is, whilst I'm firing the wire in, I ask my fluoroscopist to keep screening and changing the directions to all those directions and just get, so we're almost mimicking what I'd love to at some point. And if we don't thank the opportunity, and which I'm thankful for, if we don't discuss this, we don't get the vendors and the industry to come and support us. So it should hopefully improve glenoid positioning and accuracy, hoping that it would give you at least short-term functions, and we'd recommend them for complex cases, and these are supported by the NJR. What would be interesting is, and I don't know how to get hold of the French data, I don't think they're using computers at the moment, but those are my references, and I thank you for your time.
Thank you. Thank you very much, Dr. Mustafa, for elaborating the technology. And I still hope it's the humans using the technology, and maybe in coming future, not the technology, maybe using the humans for their own uses. So we'll move forward to the talk by our chair, Professor Pervez Hashmi, and his talk will be on anatomical shoulder versus the reverse shoulder in arthritis with an intact cuff. So it's the intact cuff which matters, or the functioning cuff that matters. Sir, please. Thank you.
Thank you, Sufyan, for inviting me to give this talk. Now, I'm really thankful for Dr. Kamran, but that he highlighted the importance of a conventional shoulder arthroplasty, because most of us, they are nowadays driven by the advancing technology, by marketing companies, and many people, they end up actually doing whatsoever is available. But one of the technique, especially if they know it very well, how to do a conventional shoulder arthroplasty, and knowing its prerequisite, it's very, very important, and it is actually little non-forgiving in terms of a placement of a glenoid component, adjustment of a humeral component, especially sizing the head, and not overloading the whole joint so that they don't stuff the joint and they do not stretch the rotator cuff. If the rotator cuff is intact and functional, that is nothing like that, that you will have a good result with a conventional shoulder arthroplasty. So, okay, I will start with, you see, this conventional shoulder arthroplasty is now gold standard for a glenohumeral end-stage disease when the rotator cuff is intact, not only intact when it is a functional. And how to determine the function of rotator cuff, not only clinical examination, but there are certain tests which we do it and to confirm the function of rotator cuff. But the reverse shoulder arthroplasty, everyone knows that it was initially invented for a rotator cuff arthropathy when the rotator cuff was incompetent. Nowadays, its indication, they have been extended, including certain complex situation in an older age group, proximal humeral fracture, and along with some glenoid defects which are not amenable to treat with a conventional shoulder arthroplasty. So, the conventional shoulder arthroplasty, or commonly we call anatomical shoulder arthroplasty, it mimics like to the normal anatomy. You replace the humeral head, you replace the glenoid concave component. But again, as I said, the prerequisite would be an intact functional rotator cuff. And you see, when I started my career earlier in 1996, I am a brachial plexus surgeon, a lot of do nerve transfer, especially opposite C7 transfer. I have around about 70, 80 cases of those, and even in the children, I do a lot of nerve transfer. I started actually do a tendon transfer in the kids, especially in Ehlers palsy. At that time, I came up this concept, and you see how deltoid is pulling the whole humeral head in upward direction. Now, this is for junior resident to make them to understand what is the function of a rotator cuff. You see, unless you understand the function of rotator cuff, you cannot actually do any proper procedure on a shoulder, especially for a conventional rotator cuff arthroplasty. And here you see, when the rotator cuff is intact, it keeps the humeral head in contact with the glenoid cavity. I always use three words. It steers, guides, and glides the humeral head during all phases of elevation. And elevation is forward flexion and abduction, as well as rotation, especially. So that is the most important function for junior resident and people who are actually fellows. they need to understand that what is the function. This is the 1996 when I actually came up with this sort of a picture, so to make them understand. Now the same thing, and one has to understand that this force coupling mechanism of a rotator cuff, which keeps the humeral head in contact with the glenoid cavity. We know that deltoid muscle is the prime mover, but its only activity and its ability to raise the shoulder depends upon the intactness of a rotator cuff. Until it is intact, then it will have a good function. So if you look at the normal biomechanics of an anatomical shoulder, if rotator cuff is intact, it actually provides a better elevation and an excellent external rotation, which we usually don't achieve in case of a reverse shoulder arthroplasty. So the implication, and earlier Idris has also showed this kind of a slide, that in a mechanically, if your rotator cuff fails because of your technical flaws, technically, if you have put a larger head or you have actually thickened your glenoid cavity and you have lateralized it, then it will overstuff the joint and it will stretch your rotator cuff. And in older age group, if rotator cuff is already incompetent, it will fail, it will put a lot of stress over the glenoid cavity and leading to early loosening and wear. Now coming to the biomechanics of reverse shoulder arthroplasty, we know that here we have reversed the whole mechanism, that we have put a convex glenosphere on the glenoid side and the concave component polyethylene cup on the humeral side. And here it has been designed initially for rotator cuff arthropathy or incompetent rotator cuff. But the basic mechanism is it was designed that the center of rotation, it was medialized as it was also inferiorized. And because of that, you see, it provides an additional mechanical advantage to the deltoid muscle, because deltoid is elongated and it tries to substitute the function of rotator cuff, and it helps in elevation and forward elevation and abduction. But here, as you see, you stretch a lot of element over the rotator cuff component, especially external rotator, infraspinatus and the teres minor, and especially in those cases where you are doing it in a proximal humeral fracture. I mean, the Kashif has shown an excellent picture that you need to reconstitute that actually lesser and greater tuberosity and try to put in a more anatomical ways so that you can get a better external rotation. But in spite of a lot of effort, still people, they cannot actually get an excellent external rotation with the reverse shoulder arthroplasty. So, reverse shoulder arthroplasty, you see, it does provide a sort of a constrained or semi-constrained implant, which has a little forgiving, and it provides a better stability, but on the cost of, you see, there would be less external rotation. And along with that, as you medialize it, you will end up doing some scapular notching. And to prevent scapular notching, now the people, they have come up with various implants where they only implants they have come and they lateralize actually the glenoid component. So if you look at the differences between these two anatomical and reverse shoulder arthroplasty component, center of rotation is almost near anatomic, while in the reverse it is inferiorized and medialized. Rotator cuff, it has to be competent, it is essential in anatomical, but it is not required in the reverse one. Deltoid function is normal, while it is a little enhanced by lengthening and by increased lever arm. External rotation is very well preserved in an anatomical shoulder, while in the reverse one, it is reduced due to an altered tension over the external rotator. Now, the joint stability and the load transmission, both they depend upon the competency of a soft tissue, especially rotator cuff. While here in reverse, you see there is intrinsic semi-constrained mechanism, and there are more compressive forces, and we say that in a reverse shoulder, this is little glenoid friendly. Implant stress is higher if the rotator cuff fails and it leads early failure, while on the reverse side, you see there are lower glenoid, lesser glenoid shear and increased humeral stress. Similarly, scapular notching we see only in the reverse one, not in actually anatomical one. So these are the actually differences which we commonly see. So which way we need to go? When a patient comes like a 60-year-old man with the osteoarthritis, glenohumeral osteoarthritis, you need to assess him carefully and discuss the pros and cons of both components. So you see, One perspective is of patient perspectives. He wants the relief in terms of a pain and some good functional range of motion, but at the same time, he also wants the longevity of that implant. It should last more than 20, 25 years. At the same time, the surgeon has to think there are three important components. One is he should see what is his indication. Second component, he should see actually the competency of rotator cuff and the pattern of bone loss. And here we see the bone loss. We see actually this is the modified Walsh classification. Type 1 is A. We know that is a concentric where in the B it is eccentric with the posterior subluxation. C is the retroversion, and the D is actually with an anterior subluxation. I will not go into the detail of those because of a time. But the rotator cuff competency, apart from clinical assessment, you need to do an EMG nerve conduction or MRI or CT scan to see any degenerative changes in the rotator cuff muscle and fatty infiltration to have a future decision, especially if it is going to fail or not. So my indication for conventional anatomical shoulder replacement is osteoarthritis with the intact rotator cuff, functionally demanding patient, and when you don't see any bone loss on the glenoid side. But if you see a bone loss on the glenoid side from B2 to B3, in those cases, it would be better if you can go to a reverse shoulder arthroplasty. So few examples, I will just actually, this is anatomical shoulder. This is other case. In one case, we did a anatomical, and other side is a hemiarthroplasty. There is another case, lady here, which I did in 2013. This was a kind of a implant reverse shoulder arthroplasty. There is another case where there was a gunshot injury, and he was a known Wazir-e-Ala of Balochistan, which I had to do reverse shoulder arthroplasty, who says degree is a degree, if people they can't recall his name. So another case of a failed reverse shoulder arthroplasty. And this is a case in which I had to do a both shoulder replacement, and initially the first on the right side and then on the left, he had actually a degenerative osteoarthritis on the both side. And this is actually his, can you run the video? Excuse me, can you run the video? So that's his functional outcome. It's actually 4 or 5 years down the line. Okay, I will just. So I'm not going to go these actually various meta-analyses. I will go at the actually end of a summary, because most of these meta-analyses, they actually favor the reverse shoulder arthroplasty. But you see, there are few things which you need to understand, and at the end I will just actually go through the summary part of these various meta-analyses. You see, the external rotation is better in an anatomical shoulder arthroplasty. Forward elevation and flexion, both they are comparable in the various series. While complication in the rear risk, especially revision, if it is not executed properly in anatomical shoulder, and if the rotator cuff fails, it is higher actually in anatomical shoulder. Glenoid loosening is also higher in anatomical shoulder, while the scapular notching is a hallmark of a reverse shoulder arthroplasty, although people, they have come up with various solutions to decrease that. So even UK National Data Registry, that also shows that there are no significant differences between the anatomical and reverse shoulder arthroplasty. But my take-home message would be, you need to understand the basic, every patient is a different patient. What pathology he has, what is the intactness of a rotator cuff, and how much there is a bone loss. And then discussing with the patient, you can actually come up with the solution that what kind of shoulder replacement you are going to do. Thank you.
Thank you, Dr. Parvez, for extremely good elaboration of the concepts. So, hemiarthroplasty is something which has gained controversial reputation So is it, am I still in the game? So for that talk, I would like to invite Dr. Saidul Thani. Sir, please, we'll love to hear your thoughts on this.
Assalamu alaikum. Good morning, everybody. So, talking about hemiarthroplasty, so maybe we need some artificial intelligence in choosing which patient we will do the hemiarthroplasty. So, here our learning objective is to choose when we operate on and we do hemiarthroplasty, what's the indication, and how can we optimize the outcome. And as we go back to history, hemiarthroplasty was started, and anatomical shoulder was maybe more than 90% of our shoulder more than 20 years back, but in the last 20 years, the shift went to the reverse, where can have a better outcome for certain patient. So what the patient want, they want pain relief, they want go back to their activities, and they need to have a longevity. So when we look at hemiarthroplasty versus total shoulder and arthroplasty, we need to look at cuff intact, we need to look at pain score, and if we compare them, we know that hemiarthroplasty maybe will associate with higher secondary glenoid erosion and conversion, but not every patient will be at the age of or the condition to have an anatomical shoulder. If you have somebody who's in their 20s or late 30s, sickle cell with avascular necrosis, or a patient with leukemia had a steroid and then they have avascular necrosis, if you will do a total shoulder, then you are burning your bridges by wasting the glenoid stock for revision. This patient will have multiple surgery in his life if he live long enough. So we need to look at not your procedure, but look at the secondary procedure. And why they failed? We failed because there is a progressive erosion. We know they will fail, but we know that we're doing them for a reason. And if you use them for B2 or B3, then you bring you're burning your bridges. But when you go back one step behind, who will have B2 and B3? These are not the young guys who will need a hemiarthroplasty. These are elderly patient who has a long-term erosion. So patients are different. So you have to look at the whole things, not just one thing. And also overstuffing, like we just talk about it with the anatomical. Overstuffing the shoulder will cause more pain and more erosion. So for me, if I have an error, I will error in having it little bit loose than little bit tight shoulder. Okay, so when we indicate it, we go back to when we use it. Younger patient, yes, post AVN, trauma, sequela, and younger patient, and also these elderlies who have reverse and failed. You can see this patient as a AVN. This guy is a sickler, 36 years old, which we eventually did a stemless hemi on him. This is one of my old patients. I did for her a reverse long time ago. For some reason, she started to have loosening around the glenoid base, and she fractured her glenoid. So she's morbidly obese and late 70s, and she said she wants one procedure. Large CTA head, hemi will work, especially with this system. I have a modularity, so I can use, I just take off the glenoid and take off the humeral base plate, and I make it a large head and try to balance the shoulder with this. So it is there to be used. When we talk about a fracture, we know most of the proximal humerus fracture, all the paper talk about elderly patient. And if you talk about middle age and younger. And there's maybe 1 or 2 articles on the literature. So hemiarthroplasty can be done for younger patient who still have mileage to go for a reverse. But the integrity, as we mentioned earlier today, it's all to do with the tuberosity healing for these patients. You need to work hard on that. When not to use, we talk about B3. You can see this patient doing a hemi, maybe it's not a good choice. This is better to think about something else. Or there's dysplasia, or there's a patient with rheumatoid arthritis, erosion. Implant choice, you can have a stemless, you can have a stemmed, breastfed, you can have a resurfacing. It is whatever good in your hand and whatever you think the patient is. This is the same patient I said, the 35 years old, where we use this ceramic hemi because we know that ceramic is better on the wear and tear over the glenoid instead of using a metal. We need to have a pre-assessment, CT scan, patient factors, MRI. We need to know which one we need to do with them. When it comes to the fracture, as I said, we need to look at the tuberosity and we need to look at how we repair the tuberosity to the implant. This is most important part of the whole procedure is to repair the glenoid. And you see how many, we call it 7 suture, 8 knot technique, where we pass it around for both lesser and greater tuberosity to achieve good healing. Rehab, as I said, early range of motion, it depends on whether it's a primary or it's a fracture. With fracture, we go a little bit slow because of we want the fracture to heal. Outcomes, we know that the primary total shoulder is superior to the hemiarthroplasty, but in certain patients, as I said, it's maybe indicated. Complications, as I said, overstuffing, erosion, and cuff failure, and maybe fractures in certain cases. You look at this patient, he was overstuffed and end up with cuff tear. So how I look at the algorithm of the patient, we need to know what is the etiology, the cuff status, glenoid wear, and age or biological demands for the patient. Intact cuff, minimal wear, young patient, AVN, post-trauma, consider hemiarthroplasty. There is osteoarthritis, maybe shoulder replacement, cuff deficiency, reverse. So these are how I look at them. What keeps hemiarthroplasty in the game? Precise indications, anatomical reconstruction without overstuffing, convertible stems, and clear counseling and follow-up. My take-home message is a primary osteoarthritis, total shoulder wins, hemiarthroplasty rarely appropriate, only in younger patients. Elderly fractures, reverse wins, hemiarthroplasty reverse for younger with the reconstructible tuberosity. Hemiarthroplasty is a niche procedure. It has to be young, intact cuff, minimum glenoid wear, and success equal to selection, technique, and conversion plan. Thank you.
Thank you very much, Dr. Said, for giving us very crisp indications, and which shows that Hemi is still in the game, but you need to be right in your indications to do it. So we'll be moving forward. So for our next talk, I'd like to invite Brigadier Khalid Masood, and he'll be talking about the shoulder arthroplasty in bone deficiencies and difficult scenarios.
थैंक यू वेरी मच. बड़ी सोफिस्टिकेटेड टॉक्स हो चुकी हैं और जो है ना I would like to discuss the practical things that we can do in our setup, or that we are doing in our setup. The topic is huge, but I have restricted it because of the time to the glenite deficiencies only. And causes of bone deficiencies are basically trauma, previous surgery, osteolysis, infection, and tumors. And arthroplasty in bone deficient cases is always challenging in terms of evaluation, types of bone loss from glenoid or humeral management, choice and availability of implant, and post-operative rehabilitation protocol. Special scenarios are when there is a severe glenoid retroversion, there is massive humeral bone loss, and there is infection or reimplantation or revision cases. Assessment includes the evaluation of the bone loss and the soft tissue loss as well. And evaluation of bone loss, we need to see whether it is a primary bone loss or due to revision cases. And glenoid bone loss and humeral bone loss. There are certain classification, but we don't go in detail. We will keep in a simple way. The glenoid bone loss are basically two types: central bone loss and peripheral bone loss. And the central bone loss can be mild or focal or central resorption. And peripheral bone loss can be the bone loss of the anterior or posterior border. And definitely there is a role of X-rays, CT with 3D reconstruction to measure the version, vault, and deficiency. And that is very good picture. We have to see the modularity, FH offset and head thickness, and the top of the humeral head should be higher than the greater tuberosity. Now the scenario is the segmental central bone loss. What should be done? Mera khayal hai most of the time we come across this when there is a cyst in the glenoid, and we come across this issue. Then the glenoid component may now be fixed in position with bone cement or bone graft inside. The next scenario is generalized central bone deficiency. Like this case, a radiograph of 67-year male patient with rheumatoid arthritis. The management is definitely the arthroplasty. But what type of arthroplasty? Rather hemi, total, or reverse. So it depends upon the bone mass of the glenoid. So we can assess the bone mass or bone deficiency of the glenoid during surgery as well. The depth of the remaining glenoid neck is critical in determination the decision to make whether a glenoid component can be placed or not. What is the technique for this? That a depth gauge is inserted into the pilot hole. एक hole बनाते हैं और वो देखते हैं कहाँ तक जाता है. I use K wire for that. If it is deep or more than 1.5 centimeter, then there is a possibility कि आप glenoid component उसके ऊपर apply कर सकते हैं. And if it is less than 1 centimeter of the depth, then the fixation for the glenoid component may not be inadequate, may not be the adequate. So there is a case with the adequate glenoid and thickness more than 1.5 centimeter, and the rotator cuff is intact. So assess the defect after reaming, and the glenoid deficiency was addressed by slight asymmetry to the reaming of the glenoid with placement of a glenoid component a bit thicker that can compensate the bone loss at the cartilage destruction. And other, if the insufficient bone is less than 1 centimeter with intact rotator cuff, then the remaining glenoid face can be recontoured with a pediatric hip reamer or special hemi-arthroplasty reamer. And a simple humeral head component can be placed against the recontoured glenoid surface. And when the bone is insufficient, it is less than 1 centimeter, and the rotator cuff is also lost, like this case. Then on CT and X-ray, we can find that the central glenoid, there is a great gross central glenoid erosion, and shape is like a funnel. And it can be seen in this sawbone model that can depict the concentric cavity glenoid bone defect. So a K-wire is directed to the area of the maximum purchase, and a bone graft can be fashioned from the humeral head, and a central hole made in the bone graft, and it is passed over the tap and impacted into the defect. Then a cannulated reamer is passed over the tap, and the graft is reamed to the level of the glenoid rim. Then one can apply the base plate for further pressure. So the graft has been impacted into the glenoid defect. Then the next scenario is the peripheral bone loss. Like a posterior glenoid deficiency, 5 millimeter or more than 5 millimeter. So it needs a reconstruction with the structural bone graft. Then a template is positioned to confirm the correct location of the central point, and a drill is placed in a central hole and oriented perpendicular to the normal remaining anterior portion of the glenoid subchondral plate. So the area of the glenoid deficiency has been freshened and a bone graft contoured and placed in the defect. It is held in position with drill for the 3.5 or 2.7 millimeter cortical, half cancellous or headless screws. I generally use headless screws. Then the second template is applied to deepen the peripheral column to allow subsequent seating of the screws. The component is now in position and faces in the normal direction of the glenoid articular surface. The screws are placed to hold the component firmly against the prepared glenoid surface and the bone graft. So the polyethylene is impacted into the position and the arthroplasty performed. This is another case with the same. So what about the revision case? It's a revision case, and there is a central bone loss in this case, and the graft has been placed, and you need to cover this defect, please, this one. So the base plate has been placed, overlies the graft material, and 2 K-wires held the bone graft in place while the glenoid was reamed and the base plate was inserted. Here, you might not need any screws. Only a hooded glenosphere should be chosen when bone graft eccentric defect. The sphere can be rotated to maximum coverage. The posterior bone graft is now held in place by the hood of the glenosphere. So there are choice of the implants now, and these implants we have in Pakistan that covers and give the more strength. So the outcomes and complications, clinical outcome in the bone deficiency cases, we can get the better range of the movement, pain relief and function, and there can be the complications like instability, component loosening, graft resorption, and there are factors for implant longevity as well. And summary of key point to success are algorithm for choosing the approach and emphasis on pre-operative planning and the emerging technology all already mentioned that 3D printing, robotic assisted orthoplasty and biologic augmentation. These are the certain references for this. Thank you very much.
Thank you very much, Brigadier Khalid, for taking this very difficult topic of shoulder arthroplasty and deficiency. So now we'll go to the last talk of the session, and I would like to invite Dr. Kashif Memon once again, and he'll be talking upon the elbow arthroplasty, my choice and outcomes. And after this talk, it will be followed by a debate session. And sir, please take us through the talk.
Thank you again, all the organizer, Prof. Mondal, for inviting me for this talk. So, elbow arthroplasty in distal humerus fractures, my choice outcomes with the latitude striker implant. And thank you to BPOS as well, which I'm part in the UK. So, overview of my presentation will be rationale for elbow arthroplasty, indication and patient selection, a little bit about the surgical technique, and a little bit about the implant design with a latitude striker system and comparison to other systems which are available in the market, and a clinical outcomes and our personal series from the UHB. So rationale for the elbow arthroplasty in fractures. Elderly patient with a complex distal radius fracture often present with irreparable comminution, especially B3 and C-type fractures. According to literature, the osteoporotic bone limits success of the internal fixation. Regarding this, one of the very good publications from the Europe, which show that predictors of failure is osteoporosis, which increases the risk fourfold of the clinical as well as radiological failures, regardless of the type of construct or hardware used for the fixations. Elbow arthroplasty provides joint stability and function and facilitates early mobilization and has a proven successful in elderly population with low demand. And AOTA guidelines 2023 update suggests that total elbow arthroplasty should be offered in elderly patient with AO type C2 and C3 fractures if bone quality is poor and reconstruction is not feasible. While in the younger patient, still ORIF is a preferred choice if you can achieve. And BASE recommends that because elbow arthroplasty is not very common procedure, so all the low volume procedures should be done at regional hubs. And in the UK, we are one of the regional hubs in the West Midland area. And most of the time, the elbow arthroplasty is done as a two consultant procedure. So patient selection and indications are very important. Ideal candidates for the elbow arthroplasty: elderly patients, again over 65 years old, 65 years of age, low demand lifestyle. Most of the time these patients are retired with AO type C2 and C3 fractures, or failed open adduction internal fixation, or non-unions, and arthritis or trauma related deformities. So contraindications for total elbow arthroplasty is again same with all any of the other joint replacement like active infection, high functional demand patients, severe soft tissue loss, and a extensor mechanism failure. Little bit comparison about the different elbow replacement system available in the market. So Latitude is a highly modular implant and their canal preparation is independent from each other, and it's a bone preserving implant with a minimal bone resection needed, and it's used for primary as well as revision cases. And the functional score, Mayo elbow performance score is over 85, and survivorship is 90 to 94% at 10 years as compared to other implants. Conrad Moray is the second most commonly used implant, which is modular, but is a shared hinge assembly, and causes more extensive bone resection than Latitude implant, and while the other implants are moderate to intermediate. So a little bit about the Latitude striker elbow system. It's as I mentioned earlier, it's a modular semi-constrained type of implant that replicates the biomechanics of the elbow. It allows for the independent preparation of the humeral and ulnar canals, and it utilizes cement component for the secure fixation, and is suitable for both primary and revision orthoplastic cases. A little bit about the surgical exposure. So I use posterior approach. I use trusses sparing approach rather than splitting approach. Some people use the osteotomy, some people use the tongue type triceps approach. Ulnar nerve must be carefully identified and protected, while transposition can be done as needed, but there are a lot of problems with the transposition. Irreparable bone fragments should be removed while minimizing the soft tissue disruption in these cases. So implantation technique, you start with the humeral side, and then you can do the reaming with the burr to start with, then with the reamers, and then the ulnar side. And once you have done the trial components, then final components can be cemented and linked to form a semi-constrained joint. Closure is usually performed in layers. I don't use the drain, but some people use the drain. So, post-operative protocol for these patients, they are in the ceiling for comfort for first 1 to 2 weeks. Once the wound is healed, then starting the early passive and active assisted range of motion. Usually extension is restricted for 6 to 8 weeks, but not for the triceps sparing approach. It's mainly for the osteotomy or tongue type triceps approach. Heavy lifting is permanently restricted for those patients. Usually we allow 2 to 3 kilos or 6 to 7 pounds, but in most of patients, they do whatever they want to do. Sometimes they don't listen. Clinical and radiographic follow-up is essential to pick up any early complications. Most of patients achieve arc of motion between 100 to 130 degrees, and the average Mayo elbow performance score is about 80, while DASH score is approximately 20. And pain-free return to daily activities typically occurs within 6 to 12 weeks with a quite high patient satisfaction reported. The complications with any of the other joint replacement, aseptic loosening, ulnar neuropathy, triceps insufficiency, again in the either osteotomy group or into the tongue type approach. Infection is again within any of the other joint replacement range, 1 to 3%. Periprosthetic fractures is a problem. So this is one of our cases. Elderly lady, I believe she was 86. She's got a type C fracture. She's got a history of osteoporosis. CT scan for the surgical planning, and she got a total elbow arthroplasty. That's a intraoperative images. Once we've done the joint replacement, we usually do the intraoperative imaging to make sure the positioning. And that's postoperative radiograph at 9 months, which shows good implant positioning again, and some sort of HO at the front. Little bit about the literature review regarding these total elbow arthroplasty in the elderly patients. So Barco found that the arthroplasty has superior outcomes to open reduction interfixation, especially with C3 fractures, while Frankel has demonstrated 10-year survivorship with latitude system. And another study showed that there is a favorable long-term outcomes with semi-constrained implants. So the biggest studies from Frankel, he showed that there are 150 total elbow replacement with mean age of 74 with excellent long-term survivorship. And this is our study from my center. I will tell a little bit about that. So it's a single center retrospective analysis, but now we are collecting the data prospective as well since I joined UHV 4 years ago. We have 15 patients in our study with mean age of 72 years, and all of those fractures were type C, and either primary total elbow was done or distal humeral hemiarthroplasty, which is another option again into the latitude system. So median follow-up in our study was 52 weeks, and functional scores was slightly less as compared to what is mentioned in the literature. I think Mayo score was 74, and the Oxford shoulder score in range of motion was comparable to the other studies. Mayo score was 75, and Oxford score was comparable, and the sorry. Can you go back for me?
Can you please show the slides again?
Okay. Yeah, the last one, yeah. So complication profile, there is one patient has got ulnar sensory symptoms, and one patient required a metal work removal with the olecranon because the other colleague has done the olecranon osteotomy, that we have to take the osteotomy metal work out. There was no infection and no revision for loosening so far yet. So our study supports that primary elbow arthroplasty, either total or hemi, is a viable option in the elderly patients where ORF open reduction internal fixation is not feasible. Overall functional results were good in our series, but we are going to publish our next portion of that with a double the number which is in this study. Limitation is again small cohort, single center design with a variable follow-up and subjective intraoperative decision, because we are 4 surgeons, we work with the pairs, and we advocate that prospective multi-center study should be conducted, which is coming soon in the UK with the name of Forest study, which we are part. So this will be a comparable study between elbow arthroplasty and fixation of the fractures in these type of fractures. Coming back to the key takeaway message from my talk will be elbow arthroplasty is highly effective in elderly patients with unreconstructible distal humerus fractures. Latitude strikers implant enables anatomical reconstruction through its modular design, but accurate technique and patient selection are crucial for the optimal outcomes. So Forest study probably will tell a little bit more about the outcome of elbow arthroplasty, but that includes both arms, total elbow and hemiarthroplasty versus open reduction internal fixation in the at the age of 65 plus in distal humerus fractures. Thank you very much.
Thank you very much, Dr. Kashif, for a very enlightening talk. So with this, we come to the end of the talks. I would like to request the chair of the session, Professor Parvez Hashmi, to kindly give his concluding remark, which will be followed by a short debate session for 30 minutes.
Thank you, Sufyan. There were excellent talks, starting with Dr. Idris, who actually gave an overview that when total shoulder arthroplasty has been done, and he also talked about some technical detail of placement of a glenoid component also. Followed by then Dr. Ijaz gave a historical perspective regarding the shoulder joint replacement, and in our country now it is in an evolution process. Although there is a lot of deficiency in terms of availability of implant, and still there are few people who are doing, but they are doing a good job to do that. Then Dr. Khalid actually gave a talk about AI facilitated. Dr. I don't know if Khalid is here or not. Shah Sahab, I just wanted to ask one question because he has actually given us thought that there are certain defects which can be reconstituted with actually custom-made implants. But the cost is an issue. There are a lot of patients who require a custom-made implant. Recently, actually, I got it from a Turkey, which cost around about 1.2 million. But that would be the cheapest. But in UK, I think it would be in many thousand pounds. Dr. Khalid, you can actually tell us that how much cost that costs. Yeah. Oh, sorry.
Okay. However, cost is not an issue for us because we live in a welfare state. The government pays for everything. The private sector also, the patient doesn't pay, the insurance pays for it, so it doesn't come out of anybody's pocket. However, in the long run, eventually the NHS is going to go bust. There's no money apparently anywhere. So hopefully cost implication will come. But I accept your point. It is an expensive implant, but the plus factors are you do one procedure instead of do one, then fail, then do another one, then fail, and then decide to put a big head, like a reverse shoulder, big head, and a hemi to make sure it goes away. But if you, in the first instance, plan where the deficiency is, either do what Khalid Saab does and put bone graft into, which is a very valid way of doing it, and especially cost-effective way in this country, or you go and get a computer to tell you what implant to use and where to use it.
Thank you, sir.
Cost is an issue, yeah.
Thank you. Then our Dr. Kashif Memon actually gave an excellent talk regarding replacement of a reverse shoulder arthroplasty and a proximal humeral fracture, especially in a type 3 and type 4. And he has illustrated how to reconstitute the greater and lesser tuberosity. My only question still actually remains, and I usually, you see, there are two scenarios. In many cases, in an older age group, you end up seeing those patients in which supraspinatus tendon is torn. If it's a torn, it's well and good, it is in our favor. But in case when the supraspinatus tendon, after reconstituting greater and lesser tuberosity, it is intact, I would like to give a little nick to the tendon of supraspinatus to give a better stretch to the deltoid muscle. What's your thought about it? Do you do it, or you just keep supraspinatus tendon intact?
No, I try to repair everything what I can according to literature, and because I work with Pascal Boileau as well and with French surgeons, and they recommend we should repair what we can. So that's why we try to repair everything what we can. If we cannot repair it because of the either say patient has got a previous cuff tear or tear or anything like that, then probably we obviously we can't repair it. Then we have to leave it. But coming back to your first question regarding the cost of ProMed, because I worked in a unit where my fellowship was with a Rivian orthoplasty surgeon, and we presented our data as well with ProMed, which is the biggest series in the whole of the world with a Lima implant, and it costs around 7,000 pounds only for the implants. But as Mr. Shah has mentioned that a cost is not an issue in the UK, but probably in the future, yes. But again, we calculate cost not for the implant only, the number of journeys patient has. So it's very important to consider the right procedure to be done by the right person at the right time, rather than getting a procedure and then failed, and again another procedure.
Thank you. And okay.
My side, that in 4-part fractures, and if they present to you late, after 2 months or 3 months, there is a definitely there is malunion of the greater tuberosities. And what is your approach in such cases? Do you go for osteotomy of the tuberosities or leave it as such?
Can I answer that question? Or do you want Kashif to answer it?
So if patient has got a malunited fracture, we will plan according to the software. And if patient is coming as a semi-elective type of patient, then I will go for augmented reality implants rather than standard implants which we use for the trauma, because that will be a slightly different scenario. And depending on the software, because we can measure the range of motion in software with the AI addition. And if that software is suggesting that we have to do the osteotomy or we have to move the tuberosities away, then we will go for that.
Yeah, in this country, you need to do the osteotomy. Tuberosity is an important structure. If you don't have tuberosity, it will not lateralize your humerus. It will not bring deltoid into function. There's no point in doing a reverse. If you put an implant in it, looks good on X-ray and doesn't have function. Tuberosities are key. I would, if I can, do an osteotomy. I know I will take a lot of help, and I've used implants now that are totally different. But in this country, osteotomy and nicking the supraspinatus, as you said, is a very valid option to make it work. Like, you know.
Agreed, Munawar, agreed. Because unless you do an osteotomy or osteoclasis, you cannot reconstitute that component of rotator cuff. And in a rotator cuff, subscapularis and the two external rotator, infraspinatus and teres minor, they are very, very important. You leave supraspinatus, you can cut the supraspinatus, and still actually you give an advantage to your deltoid muscle in an elongated position so that it can perform in a better function. So, thank you. Now the next talk was by Dr. Kamran, but he actually emphasized about the importance of a conventional shoulder arthroplasty, and rightly he actually emphasized that people, they should learn the technique properly and execute that technique properly. Following that, it was talked by Dr. Mustafa Javed, who actually emphasized about the positioning of glenoid. It was an excellent talk, and you see the modern gadgets and techniques, they do help. But you see, if a person has an experience, familiarity with his knowledge, basic anatomy, and he knows where there are the defects, then he can place, with the help of those gadgets, a better implant, and glenoid position is actually key for the success of a shoulder replacement. Then lastly, it was Dr. Saeed who talked about hemiarthroplasty. You see, still actually it holds true that if your rotator cuff, it's intact, and especially hemiarthroplasty, when you do reconstitute your rotator cuff anatomy, hemiarthroplasty still works, especially in a very older age group who have a very limited functions. And the last talk was by Dr. Khalid Masood, our Professor Vardi. He has highlighted the importance of actually various bone defects, and only experienced people, they can actually do that, because if you are not addressing the interior or posterior bone defect and you put your glenoid in a faulty position, even with some eccentric reaming, that will end up in a failure and early wear and loosening of implant. Thank you.
Thank you very much, Dr. Pervez Hashmi, for your time. So now Professor Pervez Hashmi has to leave because he has to catch a flight. Thank you so much, sir, for your time and concluding remarks. Now I'd like to request Brigadier Khalid to please continue as chair, and we'll be entering a debate session. And now is actually the time that you've heard the eminent speakers. Now it's time to involve you people, the audience sitting here. And we'll be going through very short, very crisp 5 minutes sessions with each speaker, and then we'll like to take to see a show of hands to actually see what are the actual results on it. So the first debate will be of the reverse shoulder arthroplasty. It's basically an implant design. It's an onlay versus an inlay design. So I'll be educating the inlay design, and my opponent will be respected Dr. Yasser, and he'll be talking upon the onlay implant designs, and very briefly and very crisply, then we'll take a vow from you people that what should be done. So can we have the slides, please? Okay, so talking about the reverse shoulder, we actually talk about two implant designs, which is the inlay and the onlay design. So what is that? Very briefly, if you're doing your humeral osteotomy and if your tip of the glenoid sphere is actually getting inside of the body of the humerus, that design is theoretically called as an inlay design. And if the tip of the glenoid sphere is on top of your base plate, that design is known as an onlay design. That is to be or to actually differentiate at a glance. And theoretically, why do I educate for an inlay design? Because I educated for the biomechanical advantage, the lower complication rate, and actually the growing evidence which is there in the literature regarding the inlay design. So we had the first talk of the design. What is actually the design? This is the initial Gremont design with a 155 degrees humeral neck shaft angle with an inlay humeral component which is inside. Now what it does that it moves the glenoidal rotation onto the base, onto the junction between the base plate and the bone. So it reduces the implant wear and tear from the implant to the margin of the base plate. It lengthens the deltoid fiber by actually going into elongation and distalization of the humerus and provides the stability using the semi-constrained implant. So talking about the base plate failures, now it has been shown in literature that in the inlay design, the base plate failure is theoretically is documented up to 3.2% as compared to the onlay design, which is around 8%. We talked about scapular notching. Now the inlay design has actually came up with an eccentric glenoids, which actually prevent the scapular notching, and you can get away with the problems of inlay in that design. Now what actually happens is that when the humeral component is going inside of the humerus, there is less rotation around it. The recessed component resists micromotion. And it is actually easier revision because you're not taking a lot of bone out from the humerus, and it gives you easier revisions. Now, let's everyone talk about the deltoid wrap. Now, how much strength or how much challenge you give to the deltoid. In inlay design, it's basically you're achieving it by lengthening of the inlay, and on the onlay design, you're lateralizing your humerus. So during the lateralization process, the force that you need to apply is much more to initiate your abduction. So the inlay designs have got easier and less fatigue in the elderly in initiation of your abduction, which actually is there. And later, and if you keep on lateralizing more, you don't know when you are actually more lateralizing. So you see a lot of fractures around the glenoid, you see a lot of fractures around the acromion, and you may end up in having an osteosynthesis of the acromion and the tip of the acromion and the scapular spine as well in terms of the cases. So you're basically preventing that with an onlay design. Now, overstuffing of the joint, we have talked about it. With an inlay design, the chances of overstuffing is very less. With an overstuffing, you might have difficulty in reducing the joint. So with an inlay design, you can get away with that. You cannot do, it's very easier to reduce. The joint with the repair of subscapularis, some people tend to do a subscapularis repair along with your inlay design. You can easily do that because it's less stuffed. And the neuropraxia from the nerve stretch, it is not there. And with that, all the advent, the polyethylene wear, which is not there in the inlay design. So this is one of my patients in which you can see, and you'll be hardly able to differentiate which the side of the shoulder is there. So biomechanical superiority, fewer complications, and comparable revision rates is my take in educating the inlay design. So with that, I come to my conclusion, and I'd like to invite Dr. Yasser to please give his reviews about the onlay design.
Assalamu alaikum, and thank you very much. Sufyan ने कुछ बातें बताई और कुछ बातें छुपाई, so that is fine. So we will be talking about, it's coming up somewhere soon, I hope. Okay. So I'm here to give you my 2 cents in favor of onlay. Parvez bhai chale gaye hain, Parvez Hashmi sahab, and he gave you a very nice presentation on shoulder movements, right? how the coupling of rotator cuff, deltoid contraction maintains. And if you have got a rotator cuff, we know what happens. You get a rotator cuff arthropathy, and the goal of reverse shoulder is really to try and bring that head down. ठीक है ना? पहला काम यह है कि we need to bring that head down, maintain the deltoid function to get good range of movement. And if you can do that, I guarantee you that you will have a pain-free, happy patient doing everything in her day-to-day or in his or her day-to-day activity. Now, Sufyan did mention to you that there's an inlay and an onlay, and sometimes it confuses people a lot. We don't know if it is a philosophical approach, if it is a surgical technique, is it a curse? But I think, for simplicity, the difference, as Sufyan mentioned, is really where the pivot point is. Okay, so you've got your cut, humeral cut, and if the two end meets at that line, that's an inlay. Okay, so make it things easier. And if the two end meets above your humeral cut, that's an onlay. Okay, so makes sense, right? So that's an inlay, that's an onlay. Now, before 1985, reverse shoulder or shoulder arthroplasty was a simple disaster. And it was Paul Gremont who came up with medial center of rotation for the glenoid side, and that has revolutionized the shoulder arthroplasty and the design implants. And his original design was an inlay design. Okay, so your glenoid is medialized as well as your humerus is medialized with a 155-degree inclination. Surprise, surprise, he presented his follow-up. The scapular notching was noticed in 75% after 1 year and in 88% of cases over 2 years. Sufyan ने हमें बताया कि जी scapular notching नहीं होती. That's a recent paper. Okay, with an inlay design, the incidence is up to 96% till now. Okay, despite all the advancements, you are looking at a worse clinical outcome if you are choosing an inlay design. Okay. Now, another thing that Sufyan forgot to mention is that with an inlay design, you have got a limited external rotation. Why? Because of the pull. So your humerus is medialized. The pull on the deltoid is in a different line. That makes your teres minor and infraspinatus useless. You lose external rotation. Okay, so you're trying to prevent movements pain-free, so patient should do whatever patient wants to do. And that is another problem with an inlay design. So why I prefer onlay? It gives me a better cuff function. I can, with the same medial glenoid, with medial center of rotation, I can lateralize enough to avoid all the complications. By lateralizing my humerus, I'm creating enough tension for my teres minor and infraspinatus to allow a good external rotation. Definitely, by lateralizing, there is zero scapular notching, and with inlay and scapular notching, there is higher incidence of loosening of your glenoid base plate. If we look at the recent publication, looking at the implant designs, significantly greater range of movement with an onlay implant at 3 and 12 months period. We look at Sufyan claimed that with an onlay design, we have more acromial and coracoid fractures. Not true. So over 4,000 patients, the incidence is less than 2%. And that's our recent publication. Another one, over 9,000 patients, multi-center study, 1.5% incidence of acromial and other fractures, what Sufyan was talking about. They also have one claim, which Sufyan didn't mention, that inlay group claims that with onlay implant, there is lengthening of an arm, and that causes some concerns with the patient. Again, not true. That lengthening actually, and the lengthening you would get maximum up to 10% of your arm length. You could have a lengthening with this lateralization and distalization, but this actually is good for the patient because it provides adequate tension for your deltoid and allow free range of movement. So in summary, the only implant provides better tension, better movements, lower risk of dislocation, and give my patient a pain-free, happy life. Thank you.
Thank you very much, Dr. Yasser.
Just one thing before, can we go back to the last slide, please? Just the last slide. Last slide, last slide, last slide, last slide. Yeah, this one, yeah. Jaldi mein main chala jata hoon. Okay, can we go back to the last slide?
Last slide दिखा दीजिए please.
Last slide दिखा दें please. थोड़ा सा मैं सबको यहाँ पे just want to रुक ही जाओ भैया. मैं ही कर लेता हूँ यार.
Next.
मैंने तो कुछ किया ही नहीं. ये ऊपर से.
सर ये मेरे लोग हैं सारे.
कहीं पे रोक लो. मैं छेड़ूं. ठीक है. मैं छेड़ लेता हूँ.
डिबेट नहीं जीतने देंगे सर.
वो नहीं.
प्लीज कैन यू शो द लास्ट स्लाइड प्लीज. लास्ट स्लाइड इसकी प्रेजेंट कर दें. लास्ट स्लाइड ऑन करके प्रेजेंट कर दें प्लीज. Slowly.
Aista. Or down. Just an announcement that from the platform of Pakistan Knee Society, we are starting a series of workshops or academic activities. First of it will be in Lahore as a regional course in basic sciences of orthopaedics, good for anyone who's interested for an FCPS or an FRCS orth exam. That will be held on 27th, 28th of September, and that will be one of the first of our series of workshops on basic sciences, and this will be in Lahore, sponsored by KC Pharma. Thank you. Slide nahi lagai.
This slide nahi. Please can you put the slide on. So thank you very much, Dr. Yasser. अभी I think फैसला जो है ना इंतखाबात से करते हैं. ठीक है क्योंकि let's have a review. Show of hands. So you have heard the discussion from the both sides. So all in favor of the inlay design, can you please show of hands?
People who
are all in favor of Sufyan.
Go in favor of the inlay design.
So all in favor of
audience
Sufyan,
who are
raise your
in favor of inlay implant, they can show their hand.
Inlay design.
Only जीत गया.
बस यही खत्म करते हैं. ठीक है. अगला सवाल नहीं है. So yes sir, please Mr. Shah.
None of the implants are medialized anymore. Okay, so there is a drastic change in anatomy in every implant, and that's live and learn. That's what we do. However, we must understand very importantly कि गोली और बारूद जिसने इजाद किया था ना उसने तबाही नहीं की थी. जो उसको चलाता है ना वो तबाही होती है. The surgeon is the key. It doesn't matter what implant it is. If your indications are right and do it properly, the outcome is good. You can't blame your bad outcomes on an implant.
Thank you, Mr. Shah. So we'll move on to the next debate, but unfortunately that's not going to be a debate because we have one of our speaker missing. So I'd like to invite Dr. Saeed Al Thani I think it's going to be an isolated win, but because we don't have the speaker to actually oppose him. But sir, we would like to hear your thoughts on 50 years old male with proximal humeral fracture, which is comminuted 4-part fracture with a dislocation. So your reviews on that, sir, please.
Yeah, this way I like it better, I guess. I debate myself. So, since it's going to be debate, so we have 3 patients here. We have patient A, who's a 61 years old urologist, slipped in the bathroom and fractured his shoulder. And we have patient B, is a 63 years old a police officer involved in a car accident. And the third one is a 65, 66 years old lady who again slipped after a rain and fractured her humerus. So, which one you think will be fixed? Which one will be replaced? So, for A, fix or replace? Fix. Anybody will replace? 2, fix or replace? 3, fix or replace? Okay, so let us see what we have. So we'll need to talk about the treatment, indication for arthroplasty. This is one of my review articles published last year on 3 to 4 part proximal humerus fracture in middle age and active elderly group patient. This is a review of treatment. It's a free paper. You can always access it if you want. The bottom line, the choice depends on the several factors: fracture pattern, bone quality, possibility of anatomical reduction, and cuff status, and the patient expectations. So, indications for arthroplasty: acute complex 3 to 4 part fracture in a patient above age of 65, fracture sequela, revision of failed ORIF, and relative indication: patient with relatively poor bone quality, with osteoporosis and comminution, or pre-existing cuff tear. So, reverse versus hemi, we talk about it early today that for a younger patient, hemiarthroplasty is indicated. For elderly, it's better to go with reverse arthroplasty, which give them a better outcome as compared to the hemiarthroplasty in a short and mid-term outcomes. A factor influence, as I said, for younger patient, ORIF and hemi is the choice, as we talk here. Tuberosity healing is essential for treatment. If you want to fix, you have or to replace, you need to look after the humerus tuberosity, and that will determine your outcome after this. And as I talked earlier about the 7 suture 8 knot technique, where you can see here where we pass the suture in a complex, but I will show it simply with this video. So we pass the suture through the shaft of the humerus, and then passing the implant, pass the suture around the neck. Then for the greater tuberosity, you need 2 sutures where you pass around and pass it through the 2 holes in the shaft, one below, one above, and you do the same for the lesser tuberosity. The purple suture is like a tension suture over everything at the end. I usually start with the greater tuberosity first to reduce it and tie the suture, then the lesser. Sometimes you need to debulk the tuberosity to accommodate around the implant, and then you repair the cuff overall. And the shaft, you pass it through the cuff itself to repair. So this is a meticulous technique you need to go if you want to really look after. And it should end up with the closer on this multicolors. So I will show you the first case we talk about. That's okay. So we use the, this is his fracture. You can see it's a little bit vulgously impact. And what we did, we elevated. We use a deltoid splitting technique, and we reduce, elevate the head and put a bone graft, and we plate it. You can see it, and he went to heal. This is a 3-month post-op. This is the police officer. Unfortunately, you can see it's a fracture dislocation. And you can see it is in this position. I think what they did, fixation, but the problem, if you look at the reduction, the quality, they put the head into more of a varus position. And that which allowed to fail, and he ended up with reverse arthroplasty. The 66, we have this fracture, and it was looking simple initially. So we fix it, and 3 weeks later, everything collapsed. So we end up doing a reverse for this patient. So the take-home message, hemiarthroplasty should be reserved for selected patient of young and active and reconstructible fracture, intact cuff with good tuberosity bone stock. Of course, ORAF in younger patient, like we talk about today, around 50 years old. For elderly, the choice about reverse arthroplasty is better, but the tuberosity repair is predicted for better outcome in this patient. Thank you.
Thank you.
Come to the mic, please.
Sir, how did you manage the fracture of the butterfly segment of the shaft? Can you go back, please?
Which patient?
The one with the police officer, police guy. So there was a second patient.
Which one?
Second patient.
This is second patient.
Yeah. So is it a shaft fracture as well? Isn't it? Is this artifact?
There's no shaft fracture.
Okay. Sorry. I think there was artifact. I'm sorry about that.
Okay.
Thank you. Thank you very much, Dr. Said. But there is a twist. We will still declare you the winner as a token of our respect, of our hospitality, but our second speaker has turned up. So we'd like to listen from him as well. Dr. Hussain, can you please elaborate your thoughts on saving the head? So we'll have the final decision after that, but I'm sure, Dr. Said, you will be the winner.
Assalamualaikum. I am Dr. Hussain Wahab, presenting on behalf of Dr. Faridullah Zimri Sahab. Today I would argue why fixation is a better choice in a 50-year-old patient with comminuted proximal humerus fracture with dislocation. Before going into the presentation, I would like to show a case scenario of 50 years old male, active lifestyle, functional. He presented with 4 parts fracture of the proximal humerus with dislocation. So how many of you would go for fixation in this case? And how many of you would go for reverse shoulder orthoplasty? So there are different treatment options: open reduction, internal fixation with locking plate, and fibular stud graft if there is medial support required. and reconstruction of the tuberosity or reverse shoulder orthoplasty. So in this age group, when the patients are active, working and have good bone quality, fixation is superior choice because native anatomy restoration is critical. So fixation offers joint preservation, better proprioception, and avoid lifelong prosthesis complications. Why fixation first? Because reverse shoulder orthoplasty is a salvage procedure, and fixation gives better preservation of the native joint, ideal for patients less than 60 years who have good bone stock and functionally active, allows revision options and better rotational strength, specifically external rotation and lifting strength, and it is cost effective in long term. So fixation shows better strength in less than 60 years. Reverse shoulder orthoplasty is limited for patients who are low demand or elderly because it is a deltoid based mechanism, and according to a study published in 2021, fixation gives higher satisfaction rate. So coming to the evidence, this article evaluates the outcome of the open reduction internal fixation of the proximal humerus. 63 patients were included in this study, and at 1 year follow-up, the functional outcome was very good. Forward flexion was 135 degree and 100% union rate was achieved in this series. Fixation outcome around at 50 years. So this is a cohort study which evaluates the outcome of plate osteosynthesis for proximal humerus fracture. In this study, they showed that the complication rate increases as the patient age goes above 45 years, but still good outcome is achievable in 50 years old patients who have good bone stock and they are functionally active. And they have fewer comorbidities. Why I prefer fixation over reverse shoulder orthoplasty at 50 years? Because the lifespan of the prosthesis is 10 to 15 years, and in this young age group, the patient outlives the prosthesis. So there are increasing chances of revision reverse shoulder orthoplasty, which is technically demanding and have poor outcomes if there is bone loss or tissue problem. So there are also there is a limitation in the moment, specifically external rotation and lifting strength is reduced in reverse shoulder orthoplasty. So it is a good option for elderly patient and low demand patients, but not for the active patients. So this was another study which compared the outcome of surgical fixation with open reduction internal fixation, hemiarthroplasty, and reverse shoulder orthoplasty. They showed that at 1 year follow-up, the range of motion was equal in all groups, and open reduction internal fixation showed better union rate as compared to reverse shoulder orthoplasty. Also, the reoperation rate was higher in the open reduction group, which was 17.5%, but it was also significantly high in reverse shoulder orthoplasty patients, which was 6.5%. So long-term motion outcome was comparable in both groups. But in younger age group, reoperation is not a major issue because they can tolerate further surgeries. So using a locking plate in a medial fibular stud graft gives a more stable structure, and it does not affect the viability of the articular surface. So it is a good option for the unstable four-part fractures. This was a meta-analysis and network systematic review which included 18 randomized controlled trials in a total number of patients of 1182 that shows that the reverse shoulder orthoplasty has a higher results of functional outcome and low morbidities or low complication rate in older adults, but open reduction internal fixation remains a strong choice for active young patients. So this is literature review. Better outcome with fixation. Reverse shoulder arthroplasty has less satisfactory in younger patients, and high tuberosity union rate is achievable in open reduction internal fixation with the modern techniques and the modern locking plates. The fibular graft can be used to for medial support to avoid varus compression. So reverse shoulder arthroplasty should be used as a rescue strategy, not the primary surgery, because it should be reserved for the failed fixation patients in those who have developed avascular necrosis and irreparable tuberosity. If there is failure in the fixation, so we can go for reverse shoulder arthroplasty. But if there is failure of the reverse shoulder arthroplasty, then there are limited salvage options. My final recommendation is native joint preservation is achievable, low complication burden and higher satisfaction rate in the fixation group. Thank you.
Thank you. Thank you, Dr. Saab. Thank you. So, a quick show of hands, saving the head. And reverse doing an arthroplasty. So, sir, but we still declare you as the winner, sir. Thank you very much. So, thank you. So, we'll be moving on to the last debate, which is an evidence-based decision-making, and for which I'd like to invite once again Dr. Javed Mustafa Bhalli for hemiarthroplasty in elderly versus reverse shoulder is what is required. So, Dr. Mustafa, over to you.
Thank you very much. Those were my disclosures. So moving on, so we talk about the shoulder hemiarthroplasty. We're just going to replace the head. We're using it quite more oftenly, and I think a lot of you will be more familiar with just replacing the humeral head as opposed to the entire shoulder system, and you're doing these for your elderly patients, and most of our patients who've had complications of previous surgeries, that's what we deal with here in Pakistan, and I've been told to base it on evidence from the registries. So you're looking at a shorter operative time. You know, the 70 years and older, my main concern is how much anesthetic they're going to get, and my time frame is that 90 minutes. And if you're looking at comparable outcomes in terms of pain relief and range of motion and functional ratings, and at about 5 years, you've got a shorter operative time. There is actually lower revision rates, making it a reasonable option. I mean, Dr. Nasir, with all of his Imani Kuwat, will go ahead and sort it out for us. But they're doing reasonably well. I mean, and you're, you know, somebody of my average surgical abilities can do the hemi, and we need, you know, a centralization of your reverse shoulders in a bigger trauma unit, such as Dr. Nasir's. If you look at the outcomes, I mean, sure, you're looking at a good 15-year result, and you've got a 10-year survival rate of 96%. That's not bad. American shoulder scores, again, are fairly subjective and tedious, but constant shoulder scores are fantastic, and you're getting good ranges of movement. Yeah, we're talking about, you know, greater tuberosity resorption and glenoid erosions, but you're looking at 70 plus. Most of these patients would, you know, the implants will outlive our 70-year-old patients. No way profiling, but that's what we end up seeing in Pakistan. And if we're going to compare these, and you've got meta-analysis to prove that, yeah, sure, you've got some of these scores which are doing statistically really well, but our Oxford shoulder scores, you know, are good with hemiarthroplasties, and no significant difference really in the patient-reported outcomes, where you're asking patients where they're managing their activities of daily living, and the hemis are doing really, really well, and they remain a very safe and effective options in selected cases. The National Joint Registry, you're looking at more than 11,000 of these. Yes, we know they've got a higher revision rate, but for trauma-specific cases, a good 97% survival for the 10-year survivability. So it still remains a fairly viable option. The Australians, they've had an inferior survivorship for patients who are lesser than 65, but we're talking about the elderly group. And yes, their use has declined, and I think it is all industry-driven, but if we got hold of everybody here, I think people will be far more comfortable doing a hemi as opposed to a reverse. And again, it is being used for nearly 10% of these fractures in the elderly. Again, in the Scandinavian register, look at how high the survivabilities are, and the reverse is actually lower than the other two. But again, it's the high revision which is related to the trauma settings, and this is mostly patient-reported. But resurfacings, we started with Copeland resurfacings, and they've been fantastic even for younger patients. And resurfacings have a high revision. So, yeah, okay, I'll put a stemmed implant, but I'll put a hemi in. The advantages are it's simpler, shorter surgical time, and perfect for my elderly patients. Again, and that is where the previous speakers have all alluded to that. So in my defense, it remains a valuable option for the trauma revision friendly scenarios. It has been supported by the registries. It's not a default, but I think it's got its place. So thank you for that.
Thank you very much, Dr. Javed. I think it will be a difficult task for Nasir to actually defend himself, but now we'll go to the last debate. Dr. Nasir. So, sir, please.
Thank you. Thank you, Dr. Mustafa, for elaborating your side of arguments. But I'll ask the audience that whatever they have listened since morning, if they have listened, so I will ask them what they have understood. And as Dr. Kamran Bhatt has very clearly stated, so how many of us, Allah na kare, God forbid, if my mother gets a very comminuted proximal humerus fracture, how many of us will opt for HEMI? Kindly raise your hands. And how many of us will opt for a reverse shoulder? So I think the debate is over. So I have used the tactics of my friend Yasir Mustafa Khan, who is a king of debate over here, but otherwise in the normal society he is a very soft-hearted person. But since I have been given the task, so I am going to go through the presentation. So the problem with HEMI obviously is everybody cannot reconstruct the tuberosity very well over the HEMI. So reconstruction of tuberosity, although it's a simpler procedure, but it still needs some learning curve. So you have to learn how to reconstruct the tuberosities. If it's not been reconstructed properly, the problem is malunion, non-union, and resorption. So and obviously the rotator cuff failure is there, glenoid erosion is there, and instability, and obviously no function. I did HEMI in one old lady, and then again she was like this. After that I said I'm not going to do HEMI anymore. So there has been a lot of meta-analysis showing, a lot of results in favor of reverse shoulder arthroplasty. I do not need to really go through all that because this has already been said in the previous lectures very, very clearly. So it will be just a repetition of the facts, which I think is not needed in the constraint of time. At the end, my own experience after doing that HEMI when I shifted to reverse is this. So I got a 63-year-old male. It was in 2020. This is per-operative. I tried to reconstruct the tuberosities per-operatively. This is the post-op X-ray, and this is the function which I got after 1 year. So, still it's working. Even if the tuberosity got resorbed on the reverse shoulder arthroplasty, we will still have a very good function. Now, since 2020, you see it's already been 5 years down the line, and he's doing fine. So no news is good news sometimes. This is another lady, which I also did in 2020. Now, that's the result with reverse shoulder arthroplasty. If you leave cost aside, I think there is nothing like reverse shoulder arthroplasty. Even reverse shoulder arthroplasty has started replacing anatomical shoulders. So leave aside HEMI. So I think reverse is one solution for many problems of shoulder. So I think debate is over. Thank you very much.
Thank you very much, Dr. Nasir. I think you won the debate on humanitarian grounds, but still win is a win. So thank you very much. Thank you. So yes, so we have got an announcement. The free papers has been the backbone of every conference, and in order to honor the speakers who have put their efforts in bringing up their paper, in coming up to the place, presenting them in a very nice way, the papers have been analyzed and evaluated, and there is going to be a prize distribution ceremony for the best papers who has been selected by various judges which were there as peers in the presentations which were being done. So I would like Professor Khalid Masood to actually go towards to conclude the debate session, followed by the Dr. Nasir will be actually announcing the prize distribution for the best presenters in this session. So please, Dr. Khalid.
In fact, there is a pressure that we have to leave early. So the debates were basically the first debate was reverse shoulder arthroplasty, inlay implant and onlay implant. And it was a great debate. And basically, my point of view is that we have presented the data of the other people. And what we have experienced, that is very rare now. Actual thing is that what you are doing in a different scenario and in different situations. So the debate basically your own experience. But there are so many people, they have best results with this other implant, other are very comfortable with the second implant. One is very excellent with a different technique and other is with this different technique. So it basically depends upon the how is the environment, how is the situation and what type of implant you have at the moment. So the debate was very excellent. The second was the 50-year-old male with proximal humerus comminuted fracture. That's again whether we should save the head or replace it. That is again according to the situation. What is the basically the how the patient has presented to you, and what is the age of the patient, and what is basically the type of dislocation. Sometimes there is 4-part fracture, but the parts are very close to each other. And many a times in our setup, we don't do anything and leave it conservatively, and the patient have excellent results with that. So that all depends upon the how the situation the patient has presented to you. And then the again hemiarthroplasty with versus reverse shoulder arthroplasty. So that is the time that the hemiarthroplasty is going out of scene, but there are certain definitive indications where the hemiarthroplasty has its role. But definitely in multifragmentary fracture, the reverse shoulder arthroplasty has replaced this technique now. So thank you very much, and it was a great learning session for everyone, for the presenters and for the people who attend this session. And overall, what I see that it was a great event, in fact. So there are lot of congratulations to the administration, particularly Professor Suhail Hafiz, who is sitting here, Professor Shahid Noor, and their team, Professor Suhail Amin. I feel that with the passage of time, जैसे रिप्लेसमेंट हेड थेरापी जो है ना वो रिप्लेस कर रही है हेमी आर्थोप्लास्टी को, सो दिस इवेंट इज गोइंग टू रिप्लेस द आर्थोपेडिक एसोसिएशन की जो इवेंट है उसको. So it was, people were here with great enthusiastic and very much interested, and they participated in every event. So a lot of applause for the our seniors and who are basically the started this Arthroplasty Association. So great applause for them.
Assalamu alaikum wa rahmatullah. I'm going to quickly go through. Now, free paper session is a very important session because actually it is the actual research which is going to be published. And free paper is the one that actually makes your mind think. So when we asked for the calls for free paper, a lot of people actually send us this. So we did not randomly assign that. So we first sent the papers to independent reviewers, and they reviewed the paper, and then we selected the paper to be presented on this podium. So that was the process. And once we have, the president came over here, so we actually asked 6 judges to independently mark them systematically, so that it should not be a subjective marking. So it was a very objective process, and then we calculated all the marks of 6 independent judges, and then we decided who is going to be the first. So I think the bias has been tried to be reduced to the minimum, inshallah. So I'm going to announce the third prize. Before that, I am going to ask Professor Shahid Noor to please come on stage to distribute the prizes, and the president of Pakistan Arthroplasty Society, Professor Amin Chunai. And Usman. Usman has been very instrumental in making and executing this scientific program. So the first prize, the third prize actually goes to 2 people. Dr. Khalid Zafar Qureshi, who has presented the paper on the silicon interposition for PIP. Dr. Khalid Zafar Qureshi, are you here? Actually, they were informed that they will be getting prize. I don't know. So that was a paper from Hulls, I suppose. So if Dr. Khalid is not here, then I would request his mentor, Professor Khalid Masood, to kindly collect his prize. I will request the next. Rehan. The second winner for the third prize is Dr. Rehan Ali from Liaquat National Hospital, who has presented the paper on total hip arthroplasty in young population. Good work, Rehan. Now, Rehan and Faraz and Rehan, they were the 2 guys from our Liaquat National Hospital who were behind the scene, behind this curtain, managing the presentation and all that. So big round of applause for these 2 people. Thank you very much. So second prize has again been won by 2 people. So one is Dr. Amir Shehzad. That is from PIMS. Is he here? So if Dr. Amir Shehzad is not here, then I will request Professor Ali Shami to kindly collect on his behalf. Congratulations, Dr. Ali. Dr. Ali Shami, mashallah, has been here from the Islamabad team, working day and night to make the conference successful. Thank you. The second winner for the second prize is Dr. Imran Bukhari, who actually presented a very important paper on the role of registries in presentation. So I think Pakistan National Joint Registry has revolutionized, and it's our asset. Whoever has, and our elders has actually put a lot of effort in establishing this. So we would request to kindly put your cases in registry, and this is going to be a very good tool for later on true publications. Thank you, Dr. Imran. And the first prize goes to Dr. Syed Muhammad Faraz. Excellent, Faraz, good. So he has presented a paper on the outcome of revision total knee arthroplasty or revision hip arthroplasty in 2 stages for PGI. Thank you, Faraz. Thank you very much. And this, so I will contribute the prize distribution for the free papers. Now, Dr. Hafiz Javed has to, thank you, sir. Thank you, Dr. Shahid and Dr. Amin. So, over to Dr. Hafiz Javed. नहीं, वो सबको बुलाएंगे.
Assalamu alaikum everyone. It's been exciting 3 days, and thank you everyone who has contributed in person for the organization as well as attendance. So this year we started a different activity. We made a questionnaire about products we commonly use and to understand the mechanism of products and some information about that products we commonly use in orthopedics. And we made questions for each products of most of the former which we could get hold of them before the meeting. And the idea behind was when participants take that questionnaire, they read about it, they try to understand the answer of that question, and then they go to the former stand and negotiate with them and find out the best answer. So that will educate them, the product they're using, what's the logic behind using it. So it has been quite fruitful, and there had been quite positive feedback from the different stalls as well, people engagement with them. So we got 5 winners, and we're going to announce them and with the prizes. To give the prizes, I would request Professor Dr. Suhail Hafiz to please come on the stand. And also from CCL former, I will request Ms. Farheen Badr, please come on the stage. And from Martin Door, Sabir Javed, please come on the stage as well. So we got, and Dr. Shahid, Sahib, please come on the stage as well. So we got 5 winners. And it's all been prepared by checking each and every question. So there was no lucky draw, and we checked each and every question, and the people who scored the highest have been awarded. So for the 5th, 4th, and 3rd prize, there are 3 candidates. The 5th one goes to Dr. Jamal Khan. Is he here or not? He may not be here because we tried to contact him a few times, so we'll keep his prize. The next one is Dr. Zuhaib Nadeem. So the 4th prize goes to Dr. Zuhaib Nadeem. The 3rd prize goes to Dr. Rutaba Farooq. Dr. Rutaba Farooq, she here or her representative? Please come in. Dr. Rutaba was not here. She sent her representative to get the prize. The 2nd prize goes to Dr. Hasnan Ali. And the 1st prize is for Dr. Muhammad Muzammil. He's from Karachi. So well done, everyone. Thank you very much. Sir, any concluding remarks from yourself?
Uh, this is the Solis Pharma actually has obliged the participants who has visited their stall with 3 microwave ovens. They want to keep the public warm. So the lucky draw will be taken out by our seniors, and who, if the name comes and the person is here and he has visited the stall, he will get that. The person has to be in the hall. If the name comes out and the person is not in the hall, then he missed the opportunity. Late पता चला मुझे यार. Farhan Lashari from PIMS. So he's not here. 1, 2, 3, 4, 5. 5 बोल दिया सब. बंदा गायब है. Next प्राइज निकाल. Next निकाल लेने. ये कुछ मुझे बायस लग रहा है सर.
आप हमारे यहाँ पे वार्ड में रख दीजिएगा, सबके काम आ जाएगा. तो पिम्स के वार्ड में सबके लिए, सब डॉक्टर्स के काम आ जाएगा वहाँ पे. ये बेटा ले लो आप, डॉक्टर साहब को पहुँचा दो, बल्कि पिम्स में पहुँचा देना सर के रूम में. ठीक, ओके, थैंक यू.
जल्दी जल्दी निकालो यार.
ये खुद उन्होंने फिल किए थे हमारे स्टॉल.
अब देखते हैं कि सर के मुबारक हाथों से किसका नाम निकलता है.
These were filled on the stall by the candidates themselves. Professor Irfan from Lahore.
Dr. Irfan Mehboob.
Professor Irfan Mehboob.
इरफान साहब शायद डोनेट कर दें ईदी में.
डॉक्टर ने बोला भी था.
इरफान साहब ने कहा सी एवं गल्ला बनिया ने कुछ नहीं होना. ये बेटा ले लो, इरफान साहब के रूम में रखवा देना. लास्ट एक और. ओके, कंग्रेचुलेशन. क्या हुआ? अच्छा.
Dr. Saeed Althani is going to bring the name of the 3rd luckiest person. Dilawar Khan
from Sawat.
From Sawat.
Congratulations. Thank you.
Thank you very much. Thank you very much. And I think we are running out of time. Now there's one more important thing. I request all of the audience to kindly appreciate the people who are working behind the curtains. There are a lot of our residents from Islamabad, from Karachi. I don't need to name all of them. And the people who are actually working for audiovisual, the other people who are setting the chairs for us, making arrangement for the food, and there are a lot of things are going behind. So it's not a simple thing to conference. So I would just request at least we make a round of applause for all those people who are not on the stage but has really worked very hard. Shabash. And now I will request the people to go to our young arthroplasty session, please. And please also unki bhi himmat badhaएं, because these are the people who are going to be here on the stage tomorrow. So young arthroplasty session in hall B, please. And you can actually continue over here the foot and ankle session. So, Dr. Tashfin. You can have a tea break for 10 minutes, and then I would request you to kindly gather back, or we can have a running tea. Right. We have the faculty for foot and ankle here. I think Dr. Amir, we will start the session in 5 to 10 minutes. Is that okay? Thank you very much.
आपकी आवाज आ रही है। आपको हमारी प्रेजेंटेशन सुननी है। वो अब आप उधर आप कर देंगे कि हम यहाँ से शेयर करेंगे ना उसको।
ठीक, आप वहीं से शेयर कर लें, वो ज़्यादा बेटर है ताकि वो आपके ही फुल कंट्रोल में हो।
डॉक्टर फराज, हमारी आवाज़ आ रही है? ठीक है, ओके।
अच्छा डॉक्टर साकिब, अगर आप
मैं आपको रिलीज कर रहा हूँ बस Assalamu alaikum. So we are starting the last session of the day, which is the foot and ankle arthroplasty. I will like to introduce our chair and co-chair. My name is Dr. Rizwan. I am the moderator. So we have with us Dr. Tashween Ahmed and Dr. Amir Zubairi. Dr. Tashween is from Aga Khan University Hospital, and he's a consultant foot and ankle surgeon, and Dr. Amir, who is a foot and ankle consultant in United Kingdom. So I will like the chair to open the session.
Bismillah ar-Rahman ar-Rahim. Thank you very much all for coming. And I'll talk louder so that everybody can hear us outside so they can come in. Welcome whoever is here. Rizwan will be our moderator, so I will request Rizwan to start the proceedings, please.
So we will start the session with my presentation on walking mechanics following intervention for ankle arthritis. So my talk is about a very important thing which is necessary for any kind of replacement surgery, or if we talk regarding foot arthrodesis, what mechanical change are we bringing? So I have no conflict of interest to declare. So whenever we are intervening for ankle arthritis, walking mechanics usually shows good improvements. And this talk is about what kind of things which we are achieving after we are doing either arthrodesis or ankle replacements. So before embarking into this a little boring journey, I will be sharing a small video about what is gait cycle, ताकि आपको पता चले कि मैं आगे क्या डिस्कस कर रहा हूँ, क्योंकि gait cycle भी रैंडम पढ़ते हैं बहुत ज़्यादा. Click करना.
Range of motion during the gait cycle is defined as a curve from the heel contact of a foot to the heel contact of the same foot. Gait is divided into two phases, the stand phase and the swing phase. The swing phase composes 40% of the total gait cycle, while the stand phase comprises 60% of the total gait cycle. Let's define the events that make up the stand phase. The first event is initial contact. It marks the beginning of the total gait cycle. The main goal of this event is to establish the foot contact with the ground. The foot flat at 8% is an event where the full plantar surface of the foot contacts the ground. Mid-stance at 30% is when the feeler is directly over the standing foot. Heel off at 40% marks the period when the heel lifts off the ground. And toe off at 60% is a period when the toe leaves the ground. Now, let's take a look at the swing phase events. We have three main events: acceleration 75%, mid-swing at 85%, and deceleration at 100% completing the gait cycle. Finally, let's take a look at the ranges of motion. At initial contact, the ankle is in neutral position. As the foot lowers to the ground, the ankle moves into 5 degrees of plantar flexion. As the body moves over the foot, the ankle dorsiflexes to about 10 degrees. In the last two stand phases, the ankle undergoes plantar flexion. At heel off, the ankle is neutral, and at toe off, the ankle is maximum plantar flex to about 20 degrees. At the initial contact, the knee starts off neutral, just like the ankle. Then, for purposes of shock absorption and energy conservation, it moves to about 15 degrees of flexion. At mid-stance, the knee doesn't quite fully reach the locked-out position. Once again, for purposes of energy conservation, it stays at about 5 degrees of flexion. At heel off, the knee is back to neutral position and then slowly undergoes flexion to about 30 degrees to prepare for acceleration phase of the gait. The hip is flexed to 20 degrees at initial contact. Notice that it moves from flexed position to extended position through the stance phase, and from extended to a flex position in the swing phase. At foot flex, the hip is flexed to about 15 degrees and neutral at mid-stance. At heel, the hip is in 15 degrees of extension and reaches its peak extension range of motion at jaw. Now let's take a look at the swing phase range of motion. From acceleration to deceleration, ankle dorsiflexes to clear the ground. The range of motion changes from 10 degrees of plantar flexion to 0 degrees neutral. The knee moves from maximally flexed position of 60 degrees at acceleration to fully extension at deceleration. And the hip keeps moving into a maximally flexed position at 30 degrees at deceleration. Okay, let's recap the peak ranges of motion during the week. The ankle has to be able to dorsiflex to about 10 degrees for mid-stance, plantar 20 degrees for tall. The knee has to be able to fully extend for initial contact and the heel off, and flex to about 60 degrees at acceleration. The hip has to be able to move from 30 degrees of flexion at deceleration to 20 degrees of extension at jaw. I hope this video was helpful. If you want to give it
So, अगर ये आपको समझ आ गया तो आपको मकसद पता चल जाएगा कि why are you doing. अगर आपने देखा एंकल की रेंज ऑफ मोशन कितनी है, so this is what the world is crazy about. And unlike knee replacement and hip replacements, ankle replacements have not found that kind of a pace, because 10 डिग्री अगर आप देखें dorsiflexion है और 20 डिग्री plantar flexion है. Unfortunately, till now, we are unable to produce plantar flexion in ankle replacement to the desired extent, not with comparing the arthrodesis. Arthrodesis का तो अच्छा दूसरा सबसे बड़ा मसला ये रहा walking mechanics के अंदर कि arthrodesis में nobody is worried about mechanics gait. Why? We are fusing the joint. Fuse करके मैं range of motion थोड़ी check करूँगा. So that is the key point जो आगे हम थोड़ा सा जल्दी से discuss करेंगे. Next, So in ankle arthrodesis, walking speed is reduced. आप खुद देखें ना. Walking speed, stride length, everything is decreased. So we need something जो उसको comparable कर सके. अब जब बंदा थोड़ा सा तो energy efficient गाड़ी नहीं होगी, तो energy भी ज़्यादा use कर रहा है. Stride length or cadence is number of steps per minute. अच्छा, have you seen that knee and hip are always involved in ankle motion? So if the ankle is stopped, so the compensatory mechanism will increase. The hip will flex forward ताकि वो आगे बढ़ सके. So hip पे added stress आता है. Same for the knee. The patient has to bend the knee more. So ये आपने समझना है, ये problems हैं ankle arthrodesis के साथ. So this is just a chart to show which already कहा कि increase flexion होगी compensatory में, hip पे increase extension होगी, stance. Stance is how much? 60% of the gait cycle. So इन सब चीज़ों को बेहतर करने के लिए and mobility को बेहतर and gait mechanics को we want to improve. So we need something which is better than this. So if we all know that if you are fusing one joint, the rest of the joint are under stress and can lead to arthritis as well. And increased energy consumption is basically what I discussed. So midfoot is usually compensated. आपके midfoot में patient को ज़्यादातर pain ही रहता है. So what is the difference? So if we are having some motion at the ankle joint, so we can assume that speed बढ़ जाएगी. The length of the steps, the cadence, and everything will increase as compared to arthrodesis. Range of motion, we know that the ankle dorsiflexion, but unfortunately, the power is not very much. अभी आपको आगे मैं दिखाऊंगा. And the less the compensatory motions, because natural ankle motion is almost restored, so hip or knee are not overstressed. So improve ankle, more even distribution, कोई ulcers वगैरह नहीं बनते. अगर आपने हल्का सा भी equinus में fix किया होता है तो वो patient को 4 foot ulcers हो जाते हैं. So this is very important. So this is your control. तो आप ये देखिए, sagittal range of motion is not comparable. Ankle arthroplasty cannot compare with the normal thing. That's why it's not a success at this moment of time. It is not an ideal thing like knee replacement and hip replacements. Plantar flexion आप देखें, नॉर्मल कंट्रोल का प्लांटर फ्लेक्शन 17 डिग्री तक जा रहा है और आप एंकल रेंज ऑफ मोशन के साथ अगर प्लांटर फ्लेक्शन देखें तो वो कम है, एंड डॉर्सिफ्लेक्शन की भी आप देखें तो दोनों कंपैरेबल हैं, एंड द कोरोनल मूवमेंट इज वायरस एंड वैल्गस, तो वो भी इफ यू कंपेयर आर्थ्रोप्लास्टी विद एन नॉर्मल एंकल तो इट इज नॉट वेरी गुड बट बेटर देन एंकल आर्थ्रोडिसिस. अब दिस इज द सजिटल रेंज ऑफ मोशन, आप ये देखें तो द चार्ट गोज डाउन, कंट्रोल इज -15 डिग्री and we are unable to achieve arthrodesis or arthroplasty is almost the same. So this is the ankle power. क्योंकि आपको push off के लिए you have to do plantar flexion, but if you cannot do plantar flexion because posterior mal का भी मसला है कि वो पेशेंट नहीं करता तो एनर्जी उसका पुश ऑफ वेरी वीक हो जाता है. आप देखें यहाँ पे आपको दिख भी रहा है. So that is basically the mechanics which I was next पूरा हमारा प्रोग्राम इसी पे होगा. If you understand these concepts, so everything will be fine and the choice of procedure will also be very easy for you guys. Thank you very much.
Thank you, Ridwan. While you're coming back, let me introduce the next speaker, which is Dr. Turab Sayed from Scotland. I request him to come for his talk on the current systems available for ankle arthroplasty.
Assalamu alaikum, everyone. My ask was to talk about the total ankle systems available for arthroplasty. I've tried to keep it very basic because I understand nobody does total ankle replacement in Pakistan, so I didn't want to overload, and I know there are speakers after me who are going to talk about technique and everything else. This is, if you want to look at most ankles are either 2 or 3 components, and I've tried to compare it with the normal X-ray to see what we are trying to do, and here there is hardly any joint space. And I am grateful to Rizwan for doing such a lovely presentation because I was going to talk about that why people walk like a wooden leg, but you've already shown it, so I'm not going to do the presentation of walking with a wooden leg with an arthrodesis. So that's me. I'm a senior lecturer at University of Glasgow, which is a very old establishment. It has been since around 1400, and sometimes we wonder that we need to spend more on education. And I think that's why those countries, they have got a different thing because they've been having universities for 600-700 years, while we only started having them for 200 years. So these are different kind of ankle replacements, and sometimes you have to do other procedures. And if you look at it at the end, there's a stemmed prosthesis, like you have in a knee replacement stemmed prosthesis. We have similarly stemmed prosthesis, which we sometimes use for primary when there isn't a good bone or for revision purposes. And if you're wondering where I'm based, that's here is Stirling in the central Scotland, between Edinburgh on the east coast and Glasgow on the west coast. Anybody plays golf? Yeah. So you guys would like St. Andrews over there. So you're invited. If you come to Scotland, I'll take you to St. Andrews. And when I was growing up, we had Star Trek and Data. Anybody knows Data? No? No, probably not. I'm too old. The thing is that we need to base our decisions rather than saying what the company tries to push into it, what the actual data is. Data is powerful if you start collecting your own data, and if we collect data into registry, which I'm proud that Pakistan has got no giant registry, we would make sensible decisions. And when one have to choose, like when I had to choose what total ankle replacement to do, we looked for what would allow us to do revision as well of one system, and that's why we went for Infinity. And in Edinburgh, they use Infinity and Inbone, and in Glasgow, which is on our other side, where I do refer some complex patients, they still use Star. Anybody know why a Star called a Star ankle replacement? No? Yeah, it's because Scandinavian total ankle replacement, they didn't come up with another name, so they just put that and call it a Star. Yeah. So I think this slide is obsolete now because I was trying to say that we want to preserve the joint motion, and even though we're not able to replicate normal joint, but whatever joint motion we have, the idea is that it would not affect your subtalar joint, although most of the time subtalar joint is affected because arthritis had made the ankle stiff. So subtalar and chopper joint has to do more work, talonavicular has to do more work, and then, as you said, it can affect the knee and hip as well. And sometimes if the deformity is in the hip and knee, you need to sort out the deformity in the knee and hip before you go to the ankle. And so coming on to implants, like in knee, we have got fixed bearing and mobile bearing. We started off with having fixed bearing implants. And the advantage is that they've got intrinsic instability, and there's less likelihood that the mobile bearing would ever dislocate, although it's very rare. But that results in increased stress on the bone implant interface, and that can lead to early loosening. Because if polyethylene is fixed into the tibial tray, all the stress is going over there. But if it's a mobile bearing implant, the poly is in between, which moves independently, so it takes the stress and doesn't put too much stress on the talus or on the tibia, so less chances of it becoming loose. And then there are some hybrid systems like Integra, which initially was locked, but it does have even in the H3 option that if you want to have lock as a surgeon, you want to have it locked, you can lock it or you can keep it mobile. So we call these as hybrid. Yeah. And these are some pictures. So Infinity is most commonly used system according to the NJR, and similarly the STAR system is very commonly used, but more and more people who are like me, they are going for Infinity rather than going to the STAR. But our senior colleagues, they have been using probably STAR. Yeah? No? Okay. That's fine. Yeah. So these are the few examples. So this one is the STAR one, which is and this is Salto, and then Vantage, which has got an extra coating on it, and they've got the highly cross-linked polyethylene. But all new ones, they are trying to add vitamin E into the polyethylene, and then the inbone, there was inbone 1, and now there's inbone 2. And again, you can use the stemmed prosthesis if you've got a poor or osteoporotic bone, or if you have revision. And still the thing is that you choose, it's a patient selection. You cannot do a total ankle replacement on somebody who's got a BMI of 40. In a total hip and total knee, you do it on a high BMI and you get away with it. But if you do it on a high BMI, your ankle would fail. So you normally don't tend to do it and shy away from it. And then this is STAR. Again, this is the picture what it looks like. And then as I've discussed about Hintermann, which is kind of German. And that's why it's important that you look at the issues, because Hintermann 3 recently had a FDA alert issued because of a very high revision rate, and the pre-market studies only showed 9.9%, but in real life it was going up to nearly 30%. And then you can also, depending upon how the cut on the talus is, I like to have a flat cut, but you can have a chamfer cut. Chamfer cut applies you putting a jig on to be able to get that cut. And then talus also comes either in curved or flat. And we haven't used, I know there's a talk about navigation at the end, but this is patient-specific instrument like in knees, which is by both for Hintermann and Prophecy, which is a striker implant. And I've just put this over there, like people who've got AVN, you can't go and do the ankle fusion. And if you try to do a total ankle replacement, it would fail because the talus is already dead. And if you try to put the talar implant on it, it won't work. So you can do a total talus replacement, and then on top of it, people in South Korea have got no experience of it. They are doing a total ankle replacement with the total talar replacement. And again, it would be either, initially they were all cemented. Now there's about 99% implants being put on uncemented. And again, as we showed that those with the stem, they are modular systems, and the single or monoblock are the ones like STAR. And probably it's important to know, we are currently on the 4th generation of total anchor replacement, where they've changed the coatings and all of them have got titanium. And STAR has stayed more or less, the design has stayed same, but they've changed the coating to titanium. And there's, we have ceramic hips, and there's one ceramic ankle which is only available in Japan. This is the 4th from the bottom, and but it didn't show very good results. And so I think the take-home message is that you should choose the implant if you want to do a total angle replacement based on data, and you should look at the NJR in UK. And as I said, that most of them are cementless these days. 97% are cementless, about 1 or 2% are cemented implants. And this is the number of procedures done in 2022 in England and Wales and Northern Ireland. This does not include the number for Scotland, which is around 90 to 120, depending upon what year we look at, because Scotland has got a separate called a Scottish Orthopaedic project, so we don't share data with the National Joint Registry, which was started before NJR. And I would say you need to have a system where if you need to go and do a revision, you should have, rather than do a STAR and then say, look, we can't revise it now, I have to go to inbone or something else. Thank you.
1 minute remaining.
Okay. I think I've got 1 minute, so I'll just quickly, I've made some extra slides because yesterday they kicked us out. So FDA only approved 2 component design, and STAR was initially being used as experimental, but Europe has always used 3 component designs. Is there a difference? Yes, theoretically 3 bearings or bearings, mobile bearing, and the 3 component design is supposed to have less stress, but clinically it has not shown much in the way of the difference. And if we look at Victor, who's from Basel, he's one of the well-known surgeons. He says that he would almost always use mobile bearing. He would never use a fixed bearing implant. This is STAR. We started in late 70s, almost 40 years or 35 years. And this is the 4th generation. And it makes a difference between matte and polished surfaces. So probably I think we are running out of time, so I won't spend too much time on it. But this is from total hip replacements when they did Elite, Chanley Elite, and also with the Exeter stem where they foiled when they were matte. And the reason we had polished stems were because it was a BSI standard. There was no genius that, oh, we need to make it polished because it's better. And trays have improved. And this is data showing that the 4th generation has got a better survivorship in European results, and American, they have only used 4th generation, which has got better between 88 to 95%. That's it. Thank you.
Thank you, Dr. Turab, for such a nice overview of the various types of implants available. So now we will have 2 back-to-back online talks by our esteemed faculty from Australia. Both are Pakistanis. So we will take questions in the end, I guess, because this is I will take your question. So we have got Dr. Shiraz Anjum from Wollongong, Australia. He's online with us, and he's a guy who is keen and interested in teaching us how to do foot and ankle surgeries, and is open for fellowship programs as well. Ji, Dr. Shiraz, can you hear us?
Yes, I can hear you.
Yeah, we can hear you. We can see your presentation, sir. So, Dr. Shiraz, if you are available, तो we have got things. So, थोड़ा सा program ऊपर नीचे हमने किया because of the flights. So, if you are with us, we can take you because this is definitely a bit advanced for this. क्योंकि पहले हम देख लें if you are available online. बस सही है. Thank you, sir. All right. So, thank you, sir. Thank you very much. So the next is Dr. Hong Mao Zhao. So he will be talking about patient selection and surgical indication and preoperative planning. So unfortunately he's in the flight currently, so he has sent me the recorded video for us.
choice is the self choice. So according to this, we give a choice for the following arthroplasty or the arthroplasty with additional procedures or the orthopaedic or the TBC. For the orthopaedic arthroplasty with or without additional procedures is both recording
So Dr. Zhao has merged the two slides. तो ये हम PSI का इनकी talk है उसमें शुरू करेंगे. तो next is we have Dr. Amir Zubairi, who will be talking about total ankle arthroplasty, features, surgical techniques and results.
Is it on? Yes. Assalamu alaikum. So I'll quickly go through some features, surgical technique, and results. So if I can go forward. Keyboard. All right, it's fine. I use the keyboard. My disclosures, this is where I work. So the history of ankle replacement. The attempts at ankle replacement have existed for at least 55 years. And 3-component ankle replacement prostheses are the predominant design utilized in Europe and in North America. Not only did the prosthesis change over the years, but also the patients and surgeons. Surgeons specialize in foot and ankle, improving their surgical outcomes, expanding the indications for total ankle replacement in technically demanding complex ankles. So the design objectives replicate the ankle's native dorsiflexion and plantarflexion. There was a wonderful demonstration of the gait, how it was produced, and that's what you want to replicate here. The function reliably under weight-bearing loads, and it resists wear particle generation over time, maintain hindfoot alignment and stability to protect adjacent joints. So these are the design objectives. Now, you could see that this has been some years ago that some clever surgeons have tried to invent the wheel again and use the hip prosthesis into the ankle. Of course, it didn't work, but this was the start of people thinking that there must be a way forward in doing ankle replacements. And hence, it progressed further. My colleague Turab has already alluded on some of those. The ones on the top, the star, BP, they are still in use. The one on below are going a little bit out, and I'll expand on that in a second. These are still working, although in a very short number of patients. Mobility, Zenith, and Infinity. So mobility was from early 2000 that I had experience with, and then that was taken out of market. They say it was commercial decision. There were no complications as such reported in the NGR. Zenith I took on again from 2010 onwards. This has also gone out of favor, and currently it's Infinity that is more in use, in UK at least. So Infinity is modern 4th generation fixed bearing 2-component total ankle replacement. And you'll be glad to know that we have put the debate about cemented or uncemented a lot sooner than knee replacement surgeons, and these are all uncemented. Resurfacing tailor component designed for full fluoroscopic visualization. And it is optimized for efficacy and which is prophecy for pre-op navigation and patient-specific components and tailor component interchangeability. So what do we need ankle replacement? Why do we need it? Have we seen arthritis in the ankle? If you haven't, it has certainly seen you. I'd refer you to this paper, which was published a while ago in JBJS, and the author has commented that out of 288 ankle fractures that they have investigated, they found 79% incidence of cartilage damage to various parts of the ankle. Obviously, this goes unnoticed. We fix the bone, which heals fine, but the cartilage never heals, which then leads to post-traumatic osteoarthritis. And that is the main, if you like, generator of ankle replacement. The technique. Pretty simple, really. I'll just go through it very quickly. Exposure, supine position, mark all surrounding skin, exsanguinate the limb by elevation or tourniquet. 10 to 15 centimeter midline incision centered over the middle of the talus. So you feel the medial and lateral malleolus with your finger and thumb, and you make the incision right in the middle of it. Watch out for that superficial peroneal nerve branch in the medial side, on the medial side. Retract that away, approach through EHL sheath. So you actually go through the EHL bed, carefully preserving the sheath of the tibialis anterior tendon. Retract neurovascular bundle laterally, and that's your incision onto the capsule, and you're into the joint. And expose the distal tibia, plafon, and talus through that. So just the pictures to show exactly what I just said. This is going through the tendon, neurovascular bundle, which is now retracted, and a retractor is used to do the subperiosteal dissection, both on medial and lateral side, and you're onto the ankle joint, as you can see, very arthritic looking, along with the osteophytes around it. And this is the end result after you excise the osteophytes and you're ready to do your jigging and the cuts. I'll leave that rest of it because that's not the topic. What you aim to achieve is dorsiflexion at least 10 degrees and plantar flexion of 30 degrees on table with trial prosthesis in place. The end result, you've seen these x-rays and slides in the previous presentations. I just point out that the best bone where you can get some hold is in the 1.5 centimeter of the distal tibia. Falling further up here, it is all spongious bone and fatty bone. So therefore, the strength is in this area, and therefore the implants need to go in around that and no further beyond. And hence you can see the small pegs in the tibial component that is not crossing that. About the results very quickly, that's all based on the NJR report from 2024 and a little bit from previous years as well. So with regard to ankle, this is a low volume procedure. 9,914 ankles recorded, 530 bilateral. Median age, well, you could see 17 to 97. That's a bit of a overkill on both sides. More procedures were performed in men. And if you look at the size, the material, compare with the hips and knees, this is the total numbers of procedures, and hips are that many, knees are that many, and ankles are in 8,000. So this is 1.5 million versus 8,000. So you can see the number of ankle replacements performed, which is very fewer compared to the other joints, and hence you've got less material to learn with, less material to educate people with, and therefore the technology does not improve that quickly because the industry would not like to spend money into small portion of it. So that's just a comparison of all the joints. You can see ankles, and you can see the miserable number 880 in 2022, as opposed to 98,000 knees and 99,000 hips. Elbows and shoulders are not far behind. Most used implant for ankle replacement in 2023 was Infinity, 64%, which has risen to 73% in 2025. The rest of them have remained stagnant and as it was in the previous years, so they have not gone further up, but they are still performed. There is one or two others, Hinterman and Exactech, which have got even fewer numbers. Fixation by year, that's the point I made earlier, all uncemented. These are the cemented ones. More fixed bearing than mobile bearing. Infinity is fixed bearing, and probably that's where Mobility and Zenith have come out, that they were mobile bearing, and therefore they have gone out of practice. Star is semi-constrained. It has got a central bit to keep that more fixed, if you like. So it's kind of a bit of both, best of both worlds. Out of 519 underwent revision, and the revisions were converted to arthrodesis. 337 single-stage procedures, 86 two-stage procedures, and no amputations were performed. Younger females show the highest revision rate, and the indication for revision ankle replacement were aseptic loosening and infection, as you all know, in relation to hips or knees as well. The rest of the indications are listed in the graph here. Overall, the revision rate is around 10% at 13 years. The device with infinity components now in common use has a revision rate of 4% or less than 4% at 7 years. My practice has changed to infinity in the last 5 years as well. We've performed approximately 50 odd of these so far, no revisions. This is the Integra that they presented out of 683 patients, and if you see they have got a fair bit of revision, 126 revision procedures. That's a quite high revision rate in their own paper. Mobility prosthesis, this is my review, 54 that we've done on mobility. We had 3 revisions out of it. We then had 60 patients of Zenith prosthesis, and we published that in that paper, and we had 2 revisions on that. The current prosthesis, 50 patients, we are at present reviewing them, so the results are not out on them. This is just not for fun, but for learning as well. You can see several cars in a difficult position and compromised situation everywhere. The point to make here is that the component and all those cars are very well-known brands, and there's nothing wrong with the brands. It's the driver that was at fault in most of them, and that's what the point to make, really, that you can see that you've got a best prosthesis, but if you put it wrong in different positions, then of course you won't get the right result. And therefore you need to identify where this talus is going, and if you did not identify that preoperatively, this is bound to failure. As you can see, this is all already loosening, and it loosens, and you end up with terrible situations here. So if it's a straightforward ankle, then it's a straightforward answer, but if it is not, then you might end up with situations like we've shown. The fortunate thing about ankle is that this operation is very difficult to do now in the hips, and therefore the hip replacement is always procedure of choice. And this procedure in ankle is actually a very good procedure, therefore, and it's cheaper for Pakistan, of course. So therefore, people choose this procedure because it is a good procedure to do. However, it takes away the range of motion. But if you choose carefully, and if you have a difficult situation where all joints are already arthrodesed, then you can make a good outcome following that, and that will give you best possible result. So I end up on this saying from Jim Brodsky: a great physician is the one who knows how to entertain the patient until God effects the cure. We don't effect any cure, actually. Thank you very much.
Thank you, Dr. Amir. The next talk is ankle arthroplasty in valgus ankle by Dr. Saqib Zafar. He is a consultant foot and ankle surgeon in Canberra, Australia, and is available online for us. Yeah, we are able to hear you. So yes, we can see your screen. Yeah. Yeah.
Yes, I would like to proceed with the next talk, which is by Dr. Turab Sayed on ankle arthroplasty in varus ankle.
I think my talk is very simple. If you do everything opposite of what Saqib said, that's the end of my talk. I think I would like to probably have two concepts. I wanted to have two concepts got across. One is that one should always do weight-bearing x-rays, but I think that has been hammered in by number one, so I'm not going to do it. And for a varus ankle, if we can use this 1, 2, 3 technique, that you need to start on the lateral side, on the talus, because there's an osteophyte, you need to shave that thing off. There is sometimes an osteophyte on the fibula, shave that thing off. Then go on to the medial side, because the medial side is contracted. You need to do the medial releases, or sometimes you have to do the medial osteotomy, sliding, and then come back onto the lateral side if you have to reconstruct the ATFL. If you try to start on the medial side, you would never be able to put it back in, because that piece on talus number 1 and fibula would never allow the talus to sit nicely, congruently under the joint. So it's against the nature that the problem is on the medial side. I should start on the medial side. No, you need to go and start on the lateral side, come back to the medial side, and then go back to the lateral side. Senthil Kumar is almost considered godfather or grandfather, if the grandfather is a better term than the godfather. In Scotland, he's taught most of the people who have been trained in Scotland, and he does the star ankle. And sometimes when I have problem, I refer patients to him. I do combined care of the patients that go to Glasgow for total ankle replacement. And it's very important to have somebody senior where you can bounce the ideas off and you can ask for help, and one should know the limitations. So I can go home now? Yeah. The rest is just a filler. I think we didn't talk about the thing, but varus, half of them are varus, half of them are valgus. It's very rare to get true neutral ankle. If you look really closely, there would be an element of little bit of varus and a little bit of valgus. And also the concept which I wanted to add was about being congruent, which again has been hammered in. These are the 3 different stages of the varus ankle depending upon the degree. There is no definite principle, but we think that 5 to 10 is minimal, moderate is 10 to 20, and severe is more than 20. So if you've got a severe deformity, probably discuss in your MDT and then take it rather than saying. And these days, BOFAS, which is British Orthopaedic Foot and Ankle Society, they're trying to say that we should discuss all in MDT joint replacement, and also they are trying to gear towards, although it's not happening everywhere, to have 2 consultants doing a procedure if possible. So this is the data from the Infinity study, which shows on the top is the valgus, on the bottom is the varus, that how different the degrees of valgus and varus are. And if you look at the thing, they are more or less equal. Probably they're a little bit more varus than valgus. I think we've already talked about the congruent and the non-congruent joint. And the problem is that you cannot deal with the problem by just adding more metal to it. We, as orthopedic surgeons, get excited by looking at shiny metal. And although we have used an in-bone implant there, but try to keep the bone to resection to mere minimum, because as my earlier colleague said, that if we go a further length above the physeal scar, the bone over there is very spongy and that doesn't have a very good hold. So you need to keep the bone resection to bare minimum and try to implant the implants in a good bone. And it's important, I think we have already talked about the anatomy of the foot and ankle. It's important to know the anatomy. And these are a couple of papers if we want to refresh our knowledge. And this is just a diagrammatic presentation of what a valgus varus is. And varus is not only in the ankle joint, it can be in the subtalar joint, which we said, and people can have forefoot varus. So if we look at it, it's very important to examine. So over here, the tibial plafond is in varus. This is normal. This is the talus is in varus. The hindfoot, this is the calcaneum and the subtalar joint, these are the toes, and then over here, everything is in normal, but it's the forefoot which is in varus. I think we don't have much pedobarography, but again, this would tell you that mild, moderate, and severe varus, if you have that available in your hospital, which we have in our podiatry department. And again, it's important to know that why neutral is affected by the subtalar joint. And if you look at the position of the calcaneum in both valgus and varus, the subtalar joint is affected, and in most of the ankles, subtalar joint is affected somehow. Again, I think we need to do a scanogram. We tend to do scanogram in our patients so that you can look for where the deformity is. If the deformity is in the knee and they've got knee arthritis, they should be sent to the knee surgeon first to have their knee replacement done before you embark on doing any kind of ankle replacement. So as Saqib said, that the deformity could be above the ankle in the femur, in the knee or the tibia, in the ankle joint itself, and it could be below the ankle in the subtalar joint, Chopard's joint, and I put Muller-Weiss syndrome here, where people can have uncovering of the talonavicular joint and where the forefoot looks in varus and there isn't a problem in the ankle itself. And correction is that starting off with the soft tissue releases, then do the tendon lengthening, which you would need to do for the tibialis posterior tendon. Equinus deformity, most of the varus ankles need Hoke triple cut lengthening of the Achilles tendon because it's tight. And although I've never done possible tendon transfer, but people have described where they've taken the tendon and then done the tendon transfers, then the bony procedures, and then the medial malleolar osteotomy and the hindfoot fusion. Who knows about Tom, Dick, and a very nervous Harry? This is probably the other slide I would like you to think. People have done damage to the neurovascular bundle when doing the total anchor replacement. So the now advice is you should make a small hole and put a retractor there when you're doing your cuts so that you do not damage the neurovascular bundle. If you can remember this, then you would always, when you see FHL or something else, you know that you're very closer to the neurovascular bundle. And that's the triple cut. If you can see that the foot is not only in equinus, there is an element of varus as well, and you have to do it to correct it. If you do not do it, if you just do the anchor replacement, you're going to have a very high rate of failure. So medial malleolar osteotomies are, there are two types. There is one where you do the vertical osteotomy, and the other one is the oblique. And the other thing is that most people would have a varus foot. This one is like a cavovarus, and you need to do a lateral displacement calcaneal osteotomy, which again you can do either minimally invasive surgery using bars, or you can do an open surgery, and again either you can use cannulated screws to fix the osteotomy, or you can use a step plate, which comes in different degree of displacement. And sometime you may have to do a first metatarsal osteotomy as well as dorsal closing wedge if there is a significant cavovarus foot. And I think we have already talked about this. We get a hind leg alignment view, and again I wanted to make a point about weight bearing. I write AP, but my radiographer always does a mortise view of the ankle lateral view. And weight bearing CT is not available, but if you've got weight bearing CT available, then we try to get that. And sometimes we do need MRI scan as well. It tells us how big the cysts are in the talus and the calcaneum, whether they need to be filled up or not. And this is regarding the valgus angle, so I'll skip it. So, and one needs to be aware that one can have cavovarus foot, which is as a result of Charcot-Marie tooth as well. So you need to examine their hands and look for the other signs like champagne legs. And these are some conditions or challenges you face, and then I'll put some solutions over there. And the biggest thing is that one should not go for a higher tibial cut because it increases the risk of subsidence and malleolar fracture. And the other thing is that I always assess my patients for Beaton score, which is a hyperlaxity score, to see how hyperlax they are, and pre-warn them if their Beaton score is high that they are almost always going to get lateral ligament reconstruction. And That's why sometimes doing an MRI scan helps you preoperatively, that you know how the lateral ligaments are. We can only improve our knowledge by reading, so here are some knowledge base for what we need to do. And I made some algorithms, so for soft tissue releases, you need to do the osteophyte resection, deltoid ligament peel. You peel it off the medial malleolus till a navicular joint capsule release if it's tight, tibialis posterior tendon lengthening. And then always do gutter debridement both on the medial and the lateral side. And then whether you want to do it as a single stage procedure or two-stage procedure. And varus ankle probably tends to do better than a valgus angle. As previously stated, valgus angle is even more complex, but varus is not straightforward either. And we have already discussed about the concept of the congruent joint and non-congruent. And when you've implanted, you need to check again to see if the heel is corrected or not, and then you decide whether you need to do a calcaneal osteotomy or not. And I think this is the most important take-home message. So if you can have this scheme of 1, 2, 3, this would help you. And always do soft tissue and then bones. That's it. Thank you. I think this last slide is an invitation for those who want to attend the British Pakistani Orthopaedic Society spring meeting. We would be opening up the abstracts, so you would be invited to submit your abstracts and then attend the meeting. Thank you.
Thank you very much, Dr. Turab. Next talk is, we have a slight change in program. Dr. Mohsin will follow after this talk, and he will take both talks together. So we start with Dr. Amir Zubairi's talk on revision total ankle arthroplasty.
So when you embark on doing a joint replacement, you should be prepared to deal with any complications that arise from it. And the main complication in joint replacement surgery is infection, so prevention is better than cure in relation to that. My disclosures haven't changed since the last talk. So ankle replacement is uncommon, so revision is actually rare. Patient numbers are low, the costs are high, expertise is sparse, and awareness and education is very important. Ankle replacements are more prone to loosening due to anatomical constraints and less standardized implant designs. Diagnostic imaging must be more precise, often requiring CT, MRI, etc., special tests. Special and patient-specific instrumentation is there. That is very helpful. The cumulative percentage of revision at 12 years following a primary ankle replacement is found to be 9.58%, which is comparable to other joint replacements. So 459 out of 8,000 odd underwent revision on NJR. The numbers of linked first revision is even lower. And I wonder whether there is underreporting of revision to arthrodesis, because lots of revisions end up with arthrodesis rather than another ankle replacement prosthesis. No amputations have been performed. We said that already younger females show the highest revision rates. Why revise? The reasons for revision are same as any other joint: aseptic loosening, infection, implant wear, malalignment, persistent pain, or instability. The comparative overview of loosening in joint replacements, I think that's pretty even at par with other joint replacements. So this is hip and this is knee, and that's ankle. So if you look at the incidence of loosening, it's moderate and it's about the same in others. Biomechanical stress is high here. Wear debris is significant. Fixation challenges, difficult due to small bone. Imaging sensitivity, CT, MRI performed as usual, and the others as well. Diagnostic complexity is high. Symptoms may mimic other foot and ankle issues. For example, you've done a primary ankle replacement, the patient comes back with further pain in their ankle. What do they mean by ankle? Is that ankle joint? Is that subtalar joint? It is other hindfoot joints, so it could be a mixture of those. Revision surgery complexity is quite high and is moderate in the others. So there is a little bit of a more complex issue with ankles. Pathophysiology, well, we all know where debris-induced osteolysis happens with abrasive, adhesive, fatigue, and corrosion wear. There is chronic inflammation, micromotion and mechanical instability may exaggerate the problem, and implant design and surgical technique is very important. The clinical indicators: persistent or worsening pain, especially during weight bearing, sensation of instability or giving way, or reduced range of motion or functional decline. These are all indicators that would make you think about that, whether the implant is failing. Imaging is standard radiograph, CT and MR. Lab tests, well, rule out infection any which way you'd like to. Aspiration is my gold standard. Preoperative assessment, comprehensive clinical evaluation is required. Lab investigations, all that is required for other reasons as well. Patient history, comorbidities are very important to take into account. Advanced imaging techniques, for example, CT, MRI, and prophecy, which is the patient-specific system. That is something which looks like this. So this patient of mine had metalwork in place, lots of it on the lateral and medial side, and these screws were where implant might have gone. Although this is not a revision case, but I just put it for example. So we did that prophecy investigation, and this is the result they came out with. Generally, they send a report of about 8-10 pages, which looks something like this. So they give you all the indicators, how the alignment would be, how big the implant should be, and what is the functionality of that. And they come out with the last statement saying that you need to remove either all of the implants. So that was their first report, and I said, well, this is probably a little bit too much. Remember, the people generating this report are engineers, but you are the surgeon, so you need to work out what is best for your patient's interest. So in this case, they revised their plan, and they just said that we remove the last 2 screws, and that should be fine. So that's what we ended up doing. Last screws were removed, and the implant was set in position. Surgical strategy: removal of failed components, bone grafting or augmentation, use of custom or modular implants, soft tissue balancing. So this is all done pre-operatively. How do you extract the implant? Well, in my experience, the implants are easier to remove in the ankle. They're much easier than a hip replacement, for example. But you've got all those techniques available to you, which are similar to any other joint replacement. So those are all similar availability to you. Outcomes and prognosis: well, success rate, it is a salvage procedure. When you're doing a primary ankle replacement, it's an elective procedure, patient choice. But when you're doing a revision, that becomes a necessity. It's because it is more painful for the patient, because the implant is failing, because it may be infection, because it may be that it is causing more osteolysis. So that is more of a necessity than an elective procedure. The common complications: well, prevention and management is what you look for. Long-term function and mobility, predictors are of success, and patient satisfaction is very important with specialist perspectives. So this was one of my patients who developed this problem, which is very important to predict and prevent. Here what happened is that imagine an ankle that you only got a skin and bone, so your implant is only protected by some tendons and then the skin. So if the skin breaks down, the implant is staring at you. So very careful with the skin, not using the self-retainers, and also I use immobilization after joint replacement surgery to protect the skin. And that is very important to do so while the tendons heal, because you have taken away the retinaculum, extensor retinaculum, perineal retinaculum, you've taken them away. So the tendons, especially the tibia tendon, is a very strong tendon. It will bowstring, and that bowstringing will put pressure onto the skin that you operated from, and therefore the skin can break down. So you need to give that time to heal, and therefore a cast or a splint or a boot is very important to use. So this was the patient that developed that. So we had to go back in and remove the implant, and we used the spacer, cement spacer that we created there and then, impregnated with some gentamicin, and left it for 3 months and went back. But this patient was rheumatoid, and therefore she did not have enough bone stock, so we ended up doing nail fusion for her. Now, at the time when this was performed, this implant was not available, although this may have been a choice of procedure for similar condition. So in conclusion, revision ankle surgery is more complex than primary and demanding. Avoiding complications is the message for it. It is a salvage with fusion as your backup, considering the costs, and patient-specific instrumentation is useful in these conditions. Thank you very much.
Thank you, Dr. Amir, for telling us about revision total ankle arthroplasty, and Dr. Mohsen is next. He is going to tell us some of the other complications which may necessitate revision of surgery. Yes, Dr. Mohsen.
Hello. Assalamu alaikum. My name is Dr. Syed Mohsen Ali. I'm a consultant orthopedic surgeon at John Hopkins Aramco Healthcare. Should I do this? I think complications are more than the participants watching these presentations. Unfortunately. End of the day. Okay. So my talk has already been half done by Mr. Zuberi, and some of the covered in the other talks, so it will be a quick complications. I don't have no conflict of interest. There was always a debate which is better, arthrodesis or total ankle replacement. Older paper always in favor of arthrodesis, but the new implants, as we talked and seen in previous talks, are better outcomes. So recent literature is in favor of total ankle replacement if possible. But nothing is without complication, as the previous case which was shared with by Dr. Zuberi, that we can have the most common is this infection and skin problem, because anterior approach, there's no soft tissue. So you can see simple like from the right to left, any sort of complication. You can see intraoperative complications like fracture, which is most commonly been described up to 5 to 6% possible to have intraoperative fractures. Most common is the medial mal than lateral mal. Or you can see the malalignment or subsidence of the implant which was placed wrongly. So, as I said, there are more complications possible than participants. So there's so many things. We cannot tell the patient that all 30 complications or more can happen instead. So we have to categorize them. This paper was published by Glinsbrook. I think that one of our Chinese colleagues already mentioned. He described in 29 that can be high grade, which is mainly infection, aseptic losing, and implant failure. These high grade means that more than 50% of these patients needs revision surgery. Then medium grade, which is about less than 50%, which are common technical errors, subsidence, and post-operative fracture. Low grade are like a superficial skin infection, intraoperative fractures. These can be low grade, which doesn't need any revision surgery. But this classification doesn't cover all the complications, because the superficial peroneals and things are very commonly injured because of the approach. 21% has been reported as a superficial nerve injuries damage in foot and ankle surgery. So this guy in 2014 published a paper which is the review and modification of the previous classification, and it classified only into high and low grades. But forget about the classifications. As with previous talks been mentioned about the obesity, BMI things. So I divide into two groups as a surgical student. We always divide into a categorize. So it may be a patient factor, or surgeon, or surgery related. Patient factor, we have two controversies for total ankle about the BMI, 40. It's been operated, but there are risk of complications high, but it's not a contraindication. And similarly, age, young age or older age, two extremes have a higher risk of complications. Smoking always related to the circulation problem can lead to this skin infection. You need to look at other comorbidities like diabetes and other things. And HbA1c more than 7.5 is a more risk of complications for the wound healing and things. So you have to look all these factors. The most important, the literature doesn't mention, like where I'm working in Saudi Arabia, maybe in Pakistan, the compliance of the patient. When Mr. Zubairi and Turab working, patients are more educated and they follow the instructions. Now, if you come on the surgeon and surgery-related complications, it's been well documented. If you don't have experience, there are 44 to 45% risk of complications with lesser trained surgeon, or you not doing enough cases per year. If you're doing 2 or 3 a year, definitely you're going to have some complication as compared to the centers where you're doing about half dozen or more. So these are all the soft tissue handling, as is mentioned. Don't use self-retaining retractors, malalignment, fractures, and things. So if you look at a meta-analysis, about 147 studies with almost 16,900 total ankle was in those studies, 10 most common complications you can have. These are the list. I don't need to go through this. But the problem is that in foot and ankle surgery, we don't have a high level of randomized studies and things. So if they do the grading of the quality of evidence, it was low and very low or very low. So just quickly, briefly go through the common things you can have. Is intraoperative fracture, about, as I said, 5 to 6%. Most commonly the medial mal, and about less commonly lateral mal. Why it happen? Inadequate exposure. You're pushing the jig can do a fracture. Not using your saw appropriate. You're not focusing on the medial side. If you're not putting the wires in the infinity, you can put the wires on the lateral and medial gutter, so your saw doesn't go on the sides. And these fractures, sometimes you need to fix them, and sometimes a minor fracture and this very small risk, so you can leave them alone as well. Gutter pain is another common, lateral or medial. Again, it's depending on the component design and sizing, subsidence and AVN, hypertrophic bone, and as we mentioned, if you don't control the varus or valgus, you will have an impingement. This was a commonly debate before, but a lot of research says there's nothing much difference between the fixed or mobile bearing. Wound complications we already discussed. Superficial wound complications like delayed involving is very common, but deep infection occurs 0.5% to 3.5%, which is the main cause of revision. And if you have, I just go to next slide. If you have a new pain after ankle replacement, you need to evaluate, as was mentioned by Mr. Zubairi, that you need to do some blood tests, you need to do investigation. If they are all normal, you can look for the other side, because it can be coming from the subtalar joint and things like that, or low back pain, or from the knee. Osteolysis, we know where it's coming from. You can do CT, see how big is the lesion. So this is very interesting from the MUED, from the US. So the most common is, if you look on the right side, 3 things: aseptic loosening, second is infection, and malalignment, while these are the other causes on the left side. They are further divided. What is aseptic loosening and infection? I don't need to go in that details. But if you look at the same paper, right and left, they go the complications according to the manufacturers. You know, the Stryker aseptic loosening is more common as compared to the Wright Medical, which is Infinity commonly used with instrumentation, and then Zimmer. While on this side is a more high risk of complications, so they've been getting out of fashion. So summary, complications of decay are high, variable across the studies. We don't have a great evidence in literature. Patient selection, patient counseling, surgeon experience is vital, and the training. And as Turab said, know your system. Dr. Zubairi said that know your system, what you're going to use. We know that we're doing a complex things. We go there with written the risk of death, but still we do, as an orthopedic surgeon, the things we like to do. Okay.
Thank you, Dr. Mohsin, and we'll proceed with your next talk about rehabilitation after ankle arthroplasty.
Okay, any joint surgery related to trauma or elective replacement will be not successful without rehabilitation. You do the surgery and you don't have a proper backup with their rehab people like physical therapy, you are the failure guaranteed 110%. So rehabilitation is very important because two things patient ask: when I'm going to walk, when I'm going to wear my shoe, and when I go back to my normal activities. So gait training done by physical therapists, how to learn back to the normal is very important. Second thing is the return to the activity. Normally, it's not as good as hips and knee where you can walk next day. It can take up to 2 months before you're starting as a normal, or it can take up to 6 to 12 months for fully recovery. So post-operative consideration you need to think during the rehab is the swelling and pain. The ankle movements we already discussed, that ankle movement will be not gain what you have there. Maybe a little bit gain up to 10 degree of dorsiflexion or 25 degree of plantar flexion, but total ankle will not give you extreme range of motion as compared to the other joints. The objective of rehabilitation is regaining the mobility, avoiding the stiffness, improving the strength, and enhancing proprioceptions. Rehabilitation after typically involves the initial focus as a wound care. This is a period of immobilization. I think we all immobilize a patient for first 2 weeks for the wound healing and wound care, and then you gradually increase to the weight bearing from partial weight to full weight bearing. We don't have any protocols from the manufacturing companies. I think there was a paper published. They look 7 different companies, only one has some, but that's also very debatable. If you look at the literature, their studies, meta-analysis of 48 studies, doesn't have any protocols. So there is no fixed protocols. Can we do a fast-track surgery or fast-track rehabilitation? Yes, we can do, but you need an MDT meeting and a patient selection is important. The important thing is that because we don't have much evidence, so if you're starting this project, you need to develop your own protocols based on whatever the literature available. So you have a standardized physical therapy for every patient. So, and it has to be progressively, repeatedly reassessed. So if someone left, the other person can continue the physical therapy. So we start physical rehabilitation from the time we book the patient. As soon as we book the patient, patient goes to physical therapy, which is called as a phase 1 preoperative phase. And then it's a post-operative from inpatient to discharge up to 1 year. Phase 1, as I said, is a goals. They give the crutches. They train them how to walk with the crutches. They sometimes do stairs with them. And they also do the future physical therapy protocols they will use, which is very give confidence to the patient as well. Phase 2 is from day 1 from surgery to day 14. 14th day, we remove the stitches. And this all period, the main focus is the immobilization, so wound care, DVD prophylaxis, and swelling and pain management, and deep breathing exercises. So when the patient comes 2 weeks, we change patient cast to a walking boot, and the exercise pattern or the protocols are remaining, goals are the same for the thing. So this is the. Can we play this? Can you play this video? So this is the first time we remove the cast. We start range of motion exercises for him. And we ask him to take the boot out in 2 to 3 times a day and do these exercises. Phase 4, again, I'm not going to in detail. So this phase as well, from initially partial weight to full weight bearing, we assess the swelling, we assess the pain, and we gradually, as the patient improves, we can increase the strengthening and proprioceptive receptors. So, there's a video. So this is 6 weeks. We start a patient is confident, so we start walking, mobilizing without any support. This is 10 to 14 weeks again, trying to get a normal shoes, promote more movement, strengthening exercise, and proprioception. So this is 2 Babas. On the right side of mine, he has a bilateral total ankle replacement at 3 months. And the other side, on the left side, he has a conversion from failed total ankle arthrodesis to total ankle replacement. And we start mobilizing. I give more protection if I'm converging from arthrodesis to ankle replacement. So progressively up to 1 year, you do the assessment and physical therapy. At 6 months and onward, you can start allow patient, depending on their recovery, to go for low impact activities in sports. Summary, rehabilitation is integral part of the total ankle for good outcome. Unfortunately, there is no single validated protocols in literature, no clear guidelines or protocol for manufacturing companies. Establish your own protocols with the help of literature, patient education, coordination of the therapist and surgeon is vital. Progression and assessment should be recorded on each visit at rehabilitation. Thank you. This is my son, and if you look at that, his life is dependent on the pilot who's a rehab. He cannot land himself without his instruction. So it is very important to guide the patient for a safe landing. Thank you.
I now introduce Dr. Tashfeen Ahmed from Aga Khan University Hospital.
Sir, I have a question.
Supramalleolar osteotomy, hidden friend for ankle arthritis.
I have a question.
Oh, sure, yeah.
Yes, from him. So he fully covered the total ankle arthroplasty. Regarding total ankle arthroplasty and total ankle arthrodesis, is there any age limitation in which patients we will go for arthroplasty and in which group we will go for arthrodesis? Also regarding the outcome, in which regarding age, if we look into the consideration of age, in older age, should we go for arthroplasty or arthrodesis?
See, as I said, the age is controversial and there is no consensus. But outcomes on both groups, if you see what are the literature available, don't have a randomized trials or something. You can do total ankle in a 20 years old as well. But definitely if it's very, sedentary life, it may be better. But if someone active, there may be a risk of early loosening. Okay? But as compared to on the extreme age, if you do a total ankle in a bed bone something, and you have a very poor quality of bones, so they have risk of talus fracture and things like that. So there's a two extreme life. But ideally, the age of total ankle replacement is 60 and above. Okay, but you can do in a young patient, like similarly obesity, BMI 40, 42, you can see in North America they do it. But you need to tell the patient there are risk of complications with that earlier failure, wound infection and things. So that's no contraindication in any age group, but there are risk and complication associated.
Thank you.
Okay.
My question is, usually when there is arthritis in the left knee, we say that put your stick in the right side. But the one who has done, you have underwent bilateral ankle arthroplasty, and he has also like putting stick in the right.
He has a choice to put anywhere, because of the ankle. So I don't feel any difference where to put your stick, left. I never, I do triple fusions and things. I never tell them which are they comfortable, they do it. I know in the hips and knee they say because the biomechanics of the thing, and then that the GR line and things like that. Well, I don't follow that anything. Okay. The other guy using the stick in the other hand because he's in a boot, so it helps him for that.
Thank you.
All right, Bismillahirrahmanirrahim. Assalamu alaikum. I'd like to thank the organizers for giving the opportunity to present on this topic, which is not about arthroplasty. In fact, it is about something which will prevent arthroplasty and offer an alternate method of treatment. Let's see what we can, what we feel about this procedure in the local setting. So what are you talking about? Why consider osteotomy? How to plan it? How do we know it works? And are there any other alternatives? So this is the sequence of arthritis in stages. It is categorized into these 4 stages, which includes joint space narrowing, and then there's no joint space narrowing initially, but there's sclerosis, and then medial side most commonly gets narrowing, obliteration, and bone-to-bone contact occurs then, and later on obliteration of the entire joint space can occur. So, on the other hand, there could be varus and valgus deformities, both can present, or there could be neutral. So all of these factors have to be considered now. So when there is a valgus and varus deformity, in that case, the pain could be reduced if we correct that deformity. It redistributes the weight and puts the healthy cartilage to the weight-bearing area so that the uncovered cartilage, which has eroded cartilage, has a chance to heal itself. So that's the concept of doing an osteotomy. So when we're thinking of an osteotomy, there are some things which could be problematic. For example, there are different types of osteotomy which we know, like wedge osteotomy, opening wedge, closing wedge. So if you do an opening wedge in the tibia, it could translate the ankle center or to the from like this medially. My pointer kidhar hai? Pointer to isme aa nahi raha hai. Laser काम करता है? Yeah. So if you do a wedge, it will translate it medially. So a dome osteotomy would be better because it would be, the cora would be here. In this case, the cora is at the apex. So when the cora is at the ankle, then you don't get that translational deformity. And another mistake could be to correct in one plane. If you see varus and valgus, then that may not be able to correct. If you look at this X-ray, this patient has anterior subluxation of the talus. In that case, we have to centralize it. So by doing osteotomy, we correct the varus as well as the tilt of the anteroposterior tilt. So that will result in a more neutral positioning of the dome of the talus. So if we osteotomize one, look at what is happening. In this is a valgus ankle. If we do a closing wedge here, it will try to pull the talus, but the lateral tether of the lateral collateral ligament will keep the calcaneum and the talus in persistent valgus. So we need to do a lengthening of the fibula or osteotomy of the fibula in order to allow it to assume its normal position. Otherwise, if we don't do the osteotomy, it will keep tugging on this, and that will not allow adequate reductions. If we do this, you get it. So don't ignore the other. You don't always have to do it, but you have to assess whether there is this kind of a tethering effect or not. So those are let me give you an example of a case that we did. This was a patient with traumatic injury at age 6, had multiple procedures, eventually developed a deformity. Is quite profound heel varus, as we see. And these are the heel alignment view, Saltzman view. We can see the tremendous amount of varus. This the axis of the calcaneus and axis of the tibia are very parallel and close to each other. Here we see the marked varus. And the X-rays show this. You can see the severe tilt in the talus. The tibia is oblique. It looks horizontal on the screen, but the tibia is so oblique. The medial malleolus is also deformed or dysplastic because this happened in childhood. We see osteochondral defect here. Look at cyst, subchondral cyst here on the X-ray, and probably also here. And that's what the MRI showed. Subchondral, also OCD is on the medial as well as the lateral side. He did have mild symptoms on the lateral side, but not much. So we decided only to address that. So this is a 20 degrees of deformity. If we put the tibia in neutral according to this screen, then we see this was the amount of tilt. 20-degree ankle, and even the medial malleolus seems to be the weight bearing now. In fact, the tilt of medial malleolus compared to the floor is 10 degrees. That's the severity of the deformity that he had. This was our preoperative planning for a dome osteotomy. And that's what we performed. We put in a plate, anteromedial plate, and also fixed the fibula with a K-wire. And this is the end result after, I think this was after 2 years, 2.5 years. He was totally asymptomatic now, complete symptoms gone. He had quite significant limitation of activity. Before that, he couldn't walk a long distance. Now he had no restrictions in walking. So it healed well. And this was the pre and post, if we can compare how much this was able to correct it. How do we plan it? A few tips about planning. This is another case. So this is the kind of deformity that we have. So different lines along the long axis of the tibia. The tibia also had a curvature in this case. Long axis of the tibia, long axis of the talus, the middle, joint lines. All of these we need to draw, and the different options include the unifocal dome osteotomy, which would be like this. You center on the cora, and you cut along the cora, including the fibula. That has to be, and probably a small segment needs to be resected also. So that's what you get when you do that kind of a translation. Wilsey osteotomy is another one. It doesn't need you to make a dome. You can do straight cuts, which are oblique, and then they fit into each other once you do the rotation. So the lateral part of the tibia comes here, and here this part of the tibia becomes the lateral border now. So that kind of a translation we'll see. We have to do careful calculations that can also result in a very good alignment. Opening wedge osteotomy, we've already showed you. This is how the opening would be done. You can use the resected fibula. If you do opening here, you need to resect fibula, and that you can use as a bone graft on the other side. This is how the anteroposterior inclination look. This is a retroverted ankle, and that can be corrected also with this osteotomy. Unifocal. Sometimes you need to do bifocal. For example, in this deformity, if you do a unifocal, you will end up with a deformity like this, and the axis will not be correct. So you do it two places, so there is less degree of translation on each of them. So does it work? This is a study showing that the preoperative AOFAS score was 54, and it increased to almost 80, highly significant here. This is another study which is showing adequate reduction of pain. Pain scores were much better, functional outcome was much better, range of motion of course not much different. We don't do the osteotomy to improve range of motion, we don't expect that. The main reason for doing an osteotomy is to relieve the pain and improve function. So this is a study which looked at what happens arthroscopically. Here you can see a varus ankle that was osteotomy was done, and later on this is what the finding was in the beginning. They have the completely eburnated medial talar dome, which has now completely filled up with fibrocartilage. So proof is there. What are the alternatives to this kind of an osteotomy? Plafond-plasty, which is an intra-articular osteotomy. Here we see predominantly this upgoing slope of the tibia, and that has been brought down. That has shifted the talus into a more neutral position. Then there's a distraction arthroplasty is coming up. When there's no deformity, then you just need to increase space for the cartilage. There are several studies showing that when you do distraction using an external frame, and the cartilage tends to regrow, and this is a weight-bearing X-ray after I think 2 years, which shows persistent joint space compared to over there. So this is the algorithm. We assess by radio imaging, and then if the deformity is above the ankle, a supramalleolar wedge osteotomy. Like I've shown, if it is the ankle, then either a dome osteotomy centered on the ankle or an intra-articular osteotomy would be required. If sometimes the deformity, the varus and valgus is resulting from the hind foot, like a flat foot which has a valgus subtalar joint or a valgus heel. In that case, a calcaneal osteotomy might be required, or a fusion may be required. If there's no deformity, then distraction arthroplasty, arthrodesis, ankle replacement, all of them are the options. So I have no conflict of interest with any arthroplasty company, and I have no battles with the arthroplasty surgeon also. So I'm saying this because this is what the evidence is showing, and I feel that osteotomies are great for Pakistan because no expensive implants are needed, no training on multiple different vendor inventories is required, less risk of implant complications, less functional precautions, and plan B always remains available. Take home message: arthritic ankle can be preserved and good outcome can be expected. Thank you. Rizwan is my partner in crime at Khan University. We run the foot and ankle service there. Thank you. So
all abrupt?
Yes, no. Distraction is supposed to be done gradually. Like you expect to distract to up to a centimeter or so gap that you should be able to see over a period of a month. And then later on, what our practice is to keep it like between 3 to 4 months distracted. And then we remove it and then we disconnect it and allow them to wait there with the frame, and then later on we remove the frame. Usually it improves from before. We do this procedure for pain, not to improve range of motion of the ankle. We don't expect much improvement, but some improvement does take place. All right, so now we come to the last talk of the session, which is ankle arthroplasty after ankle arthrodesis. Does it work? So by Dr. Shiraz Anjum, and he'll continue with his online talk, inshallah. Yes, please.
Thank you very much. This is the last topic of the day. I will give the presenters and this is the analysis in the room for the information of the participants. Basically, as Dr. Delegates said, generally you need 100 hit or hit patients design. Cerebral arthritis is extremely minimum, and education is also not beginning at volumes given the developing countries. So I was given the trade and convenient rather than and being takedown. So I think there is a better convenient invitation. So I go to the treatment of clinical objects. That's a technically with an education and don't have any education process is available to present the part and hopefully developing a design of the parts. The system part failure and is giving that's what I was told. My thinking of community power and we could really do addition to get the part far. There are a few notes that I would like to make before starting my presentation. One is ankle arthroplasty is not dissimilar than hernia. It's all about having a full control on your tibia and Achilles and have a full balancing. And you need to assess the deformity before you start the procedure. Few minutes were made, very nice. Basically, you want to highlight it was the key and then Dr. Corral and Dr. Berry and also as well. One of the things that I feel is the personality of the machine is the most important problem when we are talking about and this is what I will discuss. So I just present one case. I knew that I was going to short last one, so there won't be much discussion. So this is basically the representation of the physical health resources to obviously cross-validation from hospital to homes to nursing homes. Can you hear me?
Yes, we can hear you.
So she is basically involved in the non-insurgency education ambulance and other things. She has been for many years exhausted management and looking at something and she would like to go over the 4 years for getting retired. So I'm reading a series and years. So no medical issues, no medical problems. She was seeing a little coordinated surgeon. Alignment was pretty normal, no medical issues. These are X-ray and post-surgery, simple like this, ankle arthritis, everyone was decent. So somebody started to get the CPM, which was the same thing. No arthritis of the mind, and something that was quite flexible. Based on the high demand and high activities, suddenly started to do an infusion rather than replacement, and they decided to do an arthroscopic infusion to preserve the soft tissue and develop so that later on it is needed and we can take on diagnosis of the have a lot more cleaning of the delegates. If you look on the lab, we have a lot of the results while putting a cover on the joint. Anyways, 4 months post surgery, he's still very painful. He's not happy. 5 months, they did CT scan, and there is no area of the ankle where you could see bleeding bone. So they did a no chop, no infection, no metabolic disorder, reversing, and no CI, there's no nerve. So they decided to proceed with the region this time and play from a big approach, bone blocking, and approach to the screw from the side. I hope that is key. 5 months after the fact, he has not sleep. The plate is broken. She is miserable. So then I received a call with the patient and we did something. So I had a chat with the patient. She says, I'm done with the job. I don't think I can go to the patient talk to what is going to go, and I'm not able to go to the university. I always want to talk. Can you do what for me? My answer was, yes, we can, but let's see what we got. So I think in these patients, there are few things which are a little bit different than a family and one of the most important is the soft tissue development as well as actually mention and soft tissue. Post-operative issues in the patients. And it's not an infection, alignment of the ankle. Generally, I don't believe they have any problem with the alignment of the ankle. Most of the time, we believe like anyone who is related, you can do that obvious job and correct the alignment of the ankle, especially carrying the alignment. If there's any problem, it should be the ankle that we could total complex. So for soft tissue, decent shape, something is called as not arthritic, but it has still contained, and fortunately, this part of the user is get out and do the pain of CRPS, for the motion she has got a classic, very sensibility. So I decided to use the approach, remove the prosthesis, took some deep samples, and then started to assess the bones. Fortunately, there was no infection. So there was a bit more worry regarding the soft tissue, because she had 2 previous surgeries by other surgeons, and I had to take that approach out as well and plan. Once infection was cleared, then this went and did that ankle replacement. I started doing that really. She gets to see in 4 years post ankle replacement had a very improvement from 10 degrees to around 25 degrees development inflection. Fortunately, something that a different complex is still improved and she's happy. No. My feeling is ankle replacement can become of fusion, especially good hands, and very technical conditions. This is not a ankle replacement, primary replacement is not a common procedure, and to take down a fusion and to take down a failed fusion is even more complex, and nobody is not very hard. So, instead, this is improved. For me, the key area that I can see and I'm studying about any ankle replacement, the personality of the patient is motion set and non-conform. So, as we were in first opportunity, so someone is saying, I want to do bushwalking and I want to do like marathon, this and that. And you feel like I had a patient who said, maybe this fix my ankle. I don't know what pain is. Don't worry, I live in a total of 6 weeks and I will take a pain. Don't worry, so you don't want to do a replacement of those patients. Soft tissue development is the key. As we know, the most common, as Nelson mentioned, the minor complication, the most common is the soft tissue complication. So vascular disease, previous scars, skin head, previous sinuses, all of those things are important. Deformity to me is a relative complication. I generally take up to 30 degrees of operation practice, and I've been lucky so far. I've got a very high volume of deformity correction up to 30 degrees of practice without any significant issue so far. So that is a relative issue for me, not a farm issue. Other soft issue feels like the standard contraindications obviously bigger. alignment and a rigid column alignment is absolutely ballpark before you finish your replacement. And in that case, if you are keen and you want to do an replacement, people really do a single cell, as a peak mentioned and Brian mentioned that when it's very complex deformity, you can do it in 2 stages. Stage 1, you get the deformity, make sure the foot is quantified, and then in a quantified foot, you would like to put an angle. As we discussed previously, the container aspect, my feeling is to examine the patient in the home and the office, and if you see there is a various cells, this means talking to them. So that element of the pelvis, that is a complex and the various is done. So you should be very keen to address those deformities. One of the problems is just like the variability, but still they are very static. So the ligaments is there, is moving around. So that is a key for me. Like complex deformity, I will see whether the ligaments are competent during the gait cycle or not. Soft tissue balance, I believe the face is not really mobile as Rob was saying, that we do want to at least actually get lateral median coming back to lateral. In practice, if the face is not really mobile, in the end models, don't go to the process. You are going to fail. Second important thing is, I think if you look at the evidence, you have to do additional procedure at least one thing, as my colleagues mentioned, we get like a soft tissue and then transfer of pieces. My feeling is on the example, is less than 5 degrees, that get away with everything, between 5 to 10 degrees, you might need at least 10 to 15, most likely not more than 10 degrees, generally in about 90 practices. And then I'm very, very particular on video balance visualization before I do this feeling on the patient. As I mentioned, personality, one of the very I can see my practice in the last 4 years is to follow the India newspaper as a team, and I have quite a few cases together. So I don't make any mid-analysis anymore. I go on the angle video the same, but the reperception is the same as Dr. Serena mentioned, the better PhD. And I can notice that there are significantly people moving competitions. Other important thing is mentioned by most the medical fracture. I think that's it.
Hello, yes, we can hear you.
So the medial fracture is common in various injuries. I think the one of the things I have done in my practices at the PMD when I use infinity and input system. I make sure that there is at least a centimeter more between the medial shoulder of the implant and the medial end of the cortex. If the bone is less than a centimeter, I will be very, very careful that the high risk up front, medial and fracture, improperly, postoperatively, and then there's a very high chance of fracture and an injury, minimal possibility as well. So I will discuss that case and go back to the engineers if we can. If we translate it from a millimeter laterally, within that the overall alignment of the process is wrong. So I am very particular about that. So that's something that I do appreciate. So in this station, as I mentioned, the line was not prepared. Only one of the prepared was obviously that two failures, experience here, along with the fine or at least was very, very high. So I had to at least be and I didn't know this today. And they were going to start. that one cocaine, you can do 2 stages, left the party, and then come back and do the call. That's kind of the issue. Middle column, actually, again, if it is a problem, if it is the fusion required before, I think this one, I will do the fusion, then what is the problem, not to get the problem. And also, once it uses a mechanical surface, they can correct their line and put the weight, put in the best possible position, and then I will do a simple diagram of that. In this patient, the only two problems of the distance is the tightening of the release center. And the bone also is this. I generally can not use any medium play as a variant problem and most of the coating on the center surface, and they are all a little bit worried about whether the bone is going on with or not. So I can't use any bone tailors as much as I can. I feel like the results are extremely good with in-bone tailors. The problem in this case was, there is generally a stand, you don't want to put the stand as opposite one. So we ended up doing a cleaning cut on the tailors, a freehand basically. We didn't even follow the infinity protocol, and we went back and just I did a cleaning cut, and we just put that standing part. So this is a 3 millimeter plus tailors, as there was a significant bone loss in previous treatment. So I did that modification to one line. That elevation was frequent that I had done, I would say. And that's pretty much it. My talk. Any questions?
Thank you very much, Dr. Shiraz. So, yes, one question by Dr. Turab.
Is it on? Yes. Thank you ever so much, Shiraz. Did I hear you correctly? You said you do open tendo-Achilles lengthening? You don't do triple?
Mostly endoscopic.
So do you have to then change the position of the patient? Because the idea for triple cut is you can lift the leg up and do it. So if the patient is supine, how do you do the open tendo-Achilles lengthening then?
So I do better Achilles lengthening at the time of trialing because I feel that I am not able to get enough process that I leave the trial line and I put a bone under the knee and the ankle that lifts the leg up. And I try to put the maximum process that I identify that the area that I want to lengthen. And I just make 1 second cut. And I use that object, that is with sheet. And the bar through the sheet. Basically, I don't follow any objects to the basically it's my step. I can put that metal bar in and then you can put the office to the bar. I actually make a centimeter and a half bar. I will use the cat saw and I will see that I can see. I open the sheet and then I make sure that I'm also my endoscopic foot bar between the sheet and the tank. And then it's basically step by the left side and you can move it. You can cut that and
Thank you.
Thank you very much.
Can I make a comment
Yes, Dr.
Yes,
Saqib,
Saqib,
please.
So we here in Australia mostly believe in square procedures, gastric section, maybe 3 triple cut of the Achilles because it causes lengthening and weakness of the Achilles tendon, and sometimes when you are forcing dorsiflexion, you can actually cause a tear. And that, as Shiraz described as endoscopic, how you open, if you flex the knee and you make an incision midway between the just about a centimeter or centimeter and a half posterior to the medial ball of the tibia. You make only a 2 centimeter cut and you can do gastric section while patient on by simply flexing the knee, and you can actually operate on the medial side or the posterior side. So it's like a stepwise thing as you go from medial posterior to lateral, you just use that for keep the gastric knee to this tension that becomes
Thank you.
And so that you can put a line that all the way to the other side from the medial bone. Then I will use a flat cloth and then try to pull the tendon out of the bone and I start cutting it from the lateral to the medial side of the bone. And then we can do that without using the microscope. Or the other technique is that push focus speculum, which the gynecologists use for vaginal examination. You can actually use that. Good protection I also would like to make a point that all of us talked about total ankle replacement, but one system we did not discuss, and I don't know whether it's popular in Europe or not, but certainly it's done quite extensively in Australia. Similar ankle replacement, which is done through the transarticular approach. Me and Chirag have talked about a fundamental disagreement with them because it results in severe destruction of syndesmosis and the lateral incumbent because people are starting to notice it there. But give you a very good view of the current surface. The results are really shown to the enter of this one and Australian industry are pretty good. But again, it doesn't have a revision option. It's done with a lateral approach. The poly. So I don't know whether any of my guys or colleagues from UK have experience with Serena.
So, from the UK perspective, I believe what you're talking about is the agility ankle replacement, which was agility was similar. that you do transfibular approach, and you put back fibula after you finish, and you use syndesmosis screws back onto it. So this was the only ankle replacement that was approved by FDA for Americas for lots of years, and that's why they used to do that. I know Lucian has been working on this type of ankle replacement, but that hasn't made its way to Europe at all. So in Europe, this is not known, if you like. So we don't have any experience. I don't have any experience with it.
Okay, thank you very much. This brings us to the end of our session and end of the conference. In fact, I would like to thank the overseas speakers, Dr. Shiraz and Dr. Saqib, for staying with us for so long and enriching our experience. Similar to the local speakers, it was excellent to hear talks from so many people with experience in ankle arthroplasty and the other associated things. We have not started it in Pakistan formally yet. So we already know from this session many of the things which we should and we should not probably be doing. So I would like to request the chair of the session to give the concluding remarks.
Thank you. So it's really heartening to see that the Pakistan Arthroplasty Conference is promoting ankle side of things as well. This is the beginning, and you first talk about it before you put it in practice. This was like that for knee or hip replacement in Pakistan some 25, 30 years ago. So therefore, we mustn't despair that if it hasn't started here yet, it will not. So I'm pretty sure and confident that it will start here soon. We will continue to talk about it. However, the expertise need to be developed, and there is a Pakistan Arthroplasty register where this need to be recorded as well, so you learn from it. And maybe there should be some few centers where this can start initially to pool the resources and pool the expertise, if you like, and that's where it can start and spread further. And education centers can happen. This is how it happens in UK as well. It has slowly and gradually developed.
Still, the scale is small and it will always remain small because of the type of joint and the type of pathology. And so I'm very optimistic that this will continue to spread and improve, and hopefully the costs will come down as people start using it more and more. I'd like to thank everyone in attendance still, and hopefully to see everyone again in the future.
So thank you. The lunch has already been served some time ago, so please we can proceed with that. Thank you very much. Assalamu alaikum.